joyful atmosphere, but also symbolize the unity, the strength of the community. Before starting the DHIS2 Asia Pacific Conference 2024, and to express our heartfelt thanks to all for your presence, your special support to DHIS2 in the region, and your wishes for the success of the conference. We would like to introduce the Dragon and Lion dance team, along with the 5 drums, 6 cymbals, and will be performing shortly. There will be 4 themes in this special and traditional dance of Vietnamese. Event opening drummers, celebrating cymbals, twin dragon crossing the ocean, and finally is the 2 lion announcing happiness. Please welcome the performers. Thank you, the performers. I do hope that you enjoy the show. Once again, welcome to Vietnam. I'm Hương from HISP Vietnam. So now I would like to introduce three MCs of the whole conference. Please come to the stage. Sam from HISP Vietnam in Laos, Anu from HISP Vietnam and Laos, and Nghĩa from HISP Vietnam. So please welcome three MCs of the conference.
Hi everyone. Welcome to our conference, DHIS2 Asia conference. My name is Nghĩa from DHIS Vietnam, and I will MC for the conference with Sam and Anu here. Thank you.
Yes. Hi, good morning, everyone. My name is Samay Kam, or you can call me Sam. I'm with DHIS Vietnam, but based in Laos, supporting the Ministry of Laos to implement DHIS2. Yeah.
Hi, good morning to all participants. My name is Anu. I'm from DHIS Vietnam, based in Laos.
Okay, so we will be your MCs for this conference. So if you have any problem or any thing you would like to ask, please feel free to grab us. So we will be around with our colleagues. Yeah, thank you, everyone.
Okay, so hi again. So my name is Anu. So I'll be the MC for today's morning session. So before we going on with our agenda, I would like to welcome Professor Yon to give a welcome speech and introduce briefly about the history of his. Yon, please.
Hello, yeah. Yes, as it was said, I will give a brief overview of the background for HISP and the DHIS and the community. And if you all saw this timeline outside, and they was promising to get it up here also, but I don't know if that is possible. But in any case, you saw the timeline going from 1994 until then 2024, and that's then what gives the 30 years anniversary. And I will start with the beginning, but my aim of having this little speech here today is also to engage all of you to support what we can call the documentation project or research project, write up what has happened during these 30 years, because things are easily forgotten and gone, and it's important to use the opportunity now to write up the different important phases and topics and cases during this history. And you know, it's many ways to talk the history of HISP. You can talk about the technology, how that has developed. You can talk about the community, the people, maybe that's the most important, and how that has developed, and of course how they are actually going and the developing is going in tandem between the technology and the community, the HISP. And yes, we have the timeline up here now, and the timeline, as it's said here, it's divided into two. One from the start until, I think it should be okay. So it's up to 29, and we can say that this first part of the timeline is building the community, setting the stage, developing the principles that has been developed further through the whole history. And to start with the start, and it started with my PhD. So it was based at the university in Oslo, but also in Cape Town in South Africa. And interestingly enough, since we are in Asia, I will maybe focus more on the Asian part of all this development, and then we can say that my work with the start of the HISP then was actually in Mongolia. And it was my research was to compare Mongolia and South Africa in the times of change, and how can we develop information systems here. But as it went on, then South Africa became the main basis for the start of the HISP and the development of different principles, because South Africa was in a kind of a flux of change. It's a long time back now, but many of you might still remember that you had something called colonialism, and one part of that, and the very last part of, that's maybe not correct to say, but at least the last part of it was in South Africa. That was kind of the end of at least the British colonialism. And they changed everything. And I think if you look at the principles when we started, was that we wanted to bring what we call the Scandinavian tradition and approach for democratic development of information system to development in the South. And the principles were like participation, design together with the users, and that meant that you should involve the users, preferably at the local level, in developing the information systems. And we started out with the DHIS standalone system using the Microsoft Access, and what appeared was that it was quite easy to work in South Africa because they were changing everything. They were changing the data set, they were changing the districts, they were changing the provinces, etc., etc. So it was very not easy, but possible to apply the principles that we have kind of researched on in Norway and Denmark, etc., to engage the users in developing information system, because we developed system for the new district. The districts were formed there with new data sets, which were kind of developed there, indicators, and it was an enormous demand for information in South Africa. So you solved this problem of data use quite effectively, because it was a lot of differences between races, social groups, ethnic minorities and minorities in South Africa. So they wanted to measure data across the country and make sure that equity was achieved. So that was kind of the start of the data use and that focus in the DHIS. But very soon we wanted to move further out of South Africa. We started with the rest of Africa, East Africa, and built, supported by NORAD, a system of master program and PhD program, and built a community in East Africa and in India. And very, very early, already 2000, we started to work in India. So that's where the kind of the Asian connection started and comes in. And started in India, in Karnataka, Andhra Pradesh, and as we had pilot projects in South Africa, which were developed first in a few districts, and then based on success in this district, and then a province, and then another province. Then all over South Africa was kind of covered by the DHIS1 and the new data sets and indicator sets that the government approved. So that was kind of the success story that we wanted to repeat in other countries. And you see, if you look at the timeline, then we are also establishing pilot in India, in Kupam, in Andhra Pradesh, and that was a sector of one district, so it was a bit different. And we also learned that the bureaucracy and the problems of structures, etc. In India, it was not so easy to change everything overnight. And even though John was staying in these health facilities for months, sleeping there, not eating for 3 months and stuff like that, but it was difficult to move all the successes from South Africa to India at that time. But we didn't give up. And later India was very important when we started to develop the web-based DHIS, because we got criticized for sticking to this old-fashioned Microsoft non-professional, as they called it, architecture on standalone, and had to go with the new web-based system. And we started in Oslo to develop the DHIS2, as you all know, and maybe none of you remember the DHIS1, which was before. And we developed that as part of a student project, because we started this community building while building master programs, basically in Africa, but also in Sri Lanka. We had a master program which have been very formative and important in building his community as we see it now. And to go back to India, then, when we developed the DHIS2, the first implementation was in Kerala. That was in 2006. I don't know, we are here now in this pilot. But it's one thing that is important to remember is that we started with DHIS2 web-based, but on standalone PCs. So it was actually more complex to scale the new DHIS2 than the old DHIS1, we can say, because everybody knew how to install something on a Microsoft PC platform, but I mean, to install servers and everything on a PC was more complex. So, but anyway, we did the DHIS2 implementation in Kerala offline, more or less. I mean, you sent email with attachments to kind of combine the data at the state level. But that was the approach at that time. And it was very important that we actually was so stubborn on implementing this web-based system in Africa also, but first in India, despite all the problems. Because if we could actually, but first we had this master program and PhD program, and we have many people here part of that, and we have Pamod, we have John, and are there others here now? Anyway, the master and PhD programs very important part of building community, as we discussed. And when we approaching 2000, 2009, and it's still the offline system, but we also do the tracker. It was actually an evaluation of HISP saying that if you're not going to kind of more case-based in addition to the aggregate, you will not really have possibilities in the competing world of information systems. So that was also what happened, and that tracker was development in the still offline version. And we can now change over to the next phase, which is then we can call that the world of internet. And what happened? We had developed this DHIS2 and struggled to implement it offline, PC by PC by PC. And suddenly what happened was that we got a project in Kenya, East Africa, to implement DHIS2. And at that time, we did not, the internet was there, of course you can send email and all that, but you could not really go and apply this cloud computing and online servers and web-based, because the connection was not good enough. But then suddenly in 2010, end of 2010, we were actually, Ola was also there, and we were a lot of people working with this Kenya project. And then suddenly we were in a hospital to test if it was possible to connect with the server then and use the DHIS2 online. But then, I mean, it was a power break and everything went down, and no, it was not possible. So, okay, we are still not in the world of online computing, we were thinking, but then it was a Japanese volunteer who said that, why don't we try this one? And he pointed that I had a dongle, meaning something that you could, I mean, a SIM card that you could put into the laptop, and whether it was, I mean, electricity or not didn't matter, because you went to the cell towers, and then suddenly up, we were online with DHIS for the first time in Africa. And after that, it actually went quite quickly. And I think it was important, since we have been struggling with the DHIS2 offline for many years. You can say that when suddenly internet was there, we hit the ground running, to say it in that way. And all the countries in Africa subsequently went for this, based on the example of Kenya. And back to Asia, also India started with the implementation in the states, many states. So that's the important part of that early phase. And having already developed the community, or at least the basis of the community, through research, university collaboration, from Sri Lanka to Tanzania, South Africa, and Mozambique, etc. Then what happened was that in it was something called HMN at that time, Health Metric Networks, that are very active, and we started to work with them, and they had a plan to kind of reform information system more or less all over. And they had the project in a lot of countries, 50, 60 countries, etc. And also in many in Africa were working. Not Asia, I mean, was engaged in this HMN. And then they asked us, because they had designed an architecture based on a data warehouse. And then they asked us whether DHIS was good enough. And then we say, yes, it's already implemented in Kerala. So that works very fine. And they took that for a good fish, as we say in Norway. And we went on to implement it in Sri Lanka as a pilot for HMN. And then the collaboration with WHO, I mean, Ola was employed by HMN, and others from his was employed at the WHO. center ivory tower in Geneva, and it was a period where we were part of designing at least the HMI systems around. So that was an important part of the development. And later, of course, with HMN, then this Global Fund and PEPFAR, etc., also came about and became interested. And PEPFAR implemented the DHIS, and Jason is somewhere here, and he knows very well that that was possible. And that was kind of the big drive then. And if we move further on, everybody talks about data use. And of course, one important element and case of data use that we have seen is that it's important that there's a demand for information. And if we go now to the last part of this, when we come to the COVID period, we saw also again that based on the community and based on the established network, Sri Lanka started out with their solution for controlling people who came to the. You went from 5 to 1 in 1 minute. No, so it's important to look at this example of COVID, where starting out in Sri Lanka, then Laos, Indonesia, Bangladesh, and other Asian countries and African countries. It's an example of a demand-driven data use. And data use, I mean, if we manage to get those who decide to be interested in data, then data use are more easy to come by. And we have one example from Vietnam on data use, which is quite striking. Many years back, DHIS was hacked and set up to monitor accidents during the TET festival. And based on the data on the accidents cars and fireworks, and based on the data, were so striking that the government banned firework based on data from the DHIS. That went on for a couple of years, 2-3 years, and that changed the policies in Vietnam. That's one of the reasons why I want to engage everybody to write up things and look at cases and study the cases, is that those kind of small stories tend to disappear if you are not documenting them and remembering them. So that's one example that is important. Okay, I'm told that the 5 minutes are ended. Okay, thank you.
Right, thank you, Johan, for your welcome speech. A bit long, but so for our next speaker, I would like to introduce Saurabh to the stage to introduce the participants. Saurabh.
Good morning, everyone. So welcome to the 3rd annual DHIS2 Asia Pacific Conference, hosted by the DHIS2 Asia Hub. This year, we're joined by 75 participants from 10 ministries of health, 11 partner organizations, members from DHIS2 core team at the HIS Center, and my colleagues from 7 HIS groups in the Asia Pacific region. Through the conference days, we aim to exchange ideas, share innovations, and strengthen our collective efforts in building robust information systems. We'll start with the participant introductions now. In interest of time, I'll be calling out the names of the organizations attending the conference, and I'll request the representatives to please stand and receive a warm welcome from all the participants. So we'll start with the Ministries of Health first. So we'll start with the host country. So I'll request the representatives from Ministry of Health in Vietnam to please stand and receive a warm welcome from us. Ministry of Health Vietnam. Okay, they're not here right now. So we'll move on to the next country, Minister of Health, Lao PDR.
Can you hear me, or maybe I repeat my, yes. Morning everyone, my name is Thủy Phạm, I'm from USCDC Vietnam. We already support for the Ministry of Health in Vietnam in the many health sector and strengthening the health information system. Currently, with support by the HISP Vietnam, we already support for Ministry of Health to develop and the data warehouse in the national center and the regional center. We also support to develop the event-based surveillance, and maybe in the near future we continue support for the indicator-based surveillance using the DHIS2. Nice to meet you, all of you, and I will hope can talk more with you or learn from you about the system using the DHIS2 in from our country. Yes, thank you.
Thank you. So I just wanted to clarify. So I'm sure we'll have a lot of time to introduce ourselves and the work that we're doing in our tea and coffee breaks and lunch sessions. So for now, I'll just request you to stand while I call out your name and then receive a welcome from all of us. We'll have formal introductions during the breakout sessions. So next, I'll request the representatives from Minister of Health, Cambodia. Yeah, please stand. Yeah. Okay. And Minister of Health, Lao PDR. Minister of Health, Bhutan. Minister of Health, Pakistan. Minister of Health, Indonesia. Minister of Health, Maldives. Minister of Health, Occupied Palestinian Territory. We have new members joining with us. We have Minister of Health from Papua New Guinea. And Minister of Health, Sri Lanka. Next, we have a big group from WHO, from headquarters in Geneva, from Southeast Asia Regional Office, WHO offices in Lao PDR, Occupied Palestinian Territory, Vietnam, and Cambodia. So I'll request the WHO contingent to please stand. Colleagues from UNICEF. UNFPA. We have colleagues from World Bank. We have colleagues from FHI 360. JSI Research and Training Institute. US CDC Vietnam. We have from Nepal Standards and Interoperability Lab. Catapult Digital. Nepal Health Research Council. And International Organization for Migration, IOM. We have DHIS2 experts from the HIS Center at UIO, so requesting all UIO colleagues to stand, please. We have his colleagues here, so his group Vietnam and Laos. Bangladesh, India, Indonesia, his Pakistan, Middle East and North Africa, and his Sri Lanka. Okay. So once again, a warm welcome from the HIS2 Hub to all the participants. For the next session, I'll hand over to Anu to take you through the conference agenda. Thank you so much.
Yes, thank you, Saurabh. So I would like to go through the agenda for today. So for our first session, there will be a welcome from HIS2 Asia Hub. We will learn more about Global HIS2 Network. There will be a signing of HIS2 principle by HIS2 Asia groups, and we will learn more about the regional HIS2 Asia Hub model. And from 10:30 to 11 a.m., we will have a group photo and a short tea break at the foyer outside. And then we will continue with a review of new and upcoming features in DHIS2. Then from 12:30 to 1:30 p.m., we will have a buffet lunch at the restaurant on the 3rd floor. So we will have 1 hour for lunch. And our afternoon session will start at 1:30 p.m., which we will hear from a number of countries who will present on their local DHIS2 implementations. We will have another short tea break from 3 to 3:30. And then from 3:30, we will have what we call parallel sessions. So we will have 2 parallel sessions. So at the same time, so session 1, we're focusing on ICD 11 for morbidity and mortality. And session 2 is focusing on education and health. So our session Yes, sorry about that. So our session for today will end around 5 p.m. And then we would like to invite all participants to our gala dinner on the restaurant on the 25th floor, which will start around 6 p.m. So regarding our parallel session, we would like you all to scan the QR code I have up here for Menti. We would like to ask about your opinion of which session that you want to join today, which our agenda will be adjusted based on the session that all participants want to join. So yes, please. Yes, so I would like to go to the first question. So for the first day session, so there is 29 participants who want to join the ICT session and around 19 who want to join the health and education session. I'm sorry, I forgot to review the agenda for the parallel session for the second day and the third day. So these are the sessions for the second day, which is tomorrow. So we have data quality and metadata toolkits, which around 32 of our participants prefer to join, and then other 16 wants to join on the system assessments and the core team. And for our last day parallel sessions, we have visualization tools in DHIS2, which around 21 participants would like to join, and then we have a parallel session on integration, which we have now 28 participants. Yes, so thank you all participants for participating in our mentee survey. And I would like to present you all a useful links for this conference. So the QR code on the left will be where you can get all our materials and recording for this conference, and the QR code on the right is where you can share your photos of the conference. And another note from our organizer, so for the Wi-Fi of this conference, please connect to DAP 2024. So I will leave this slide here, and now I would like to invite Hyung on the stage to review on the logistics.
Okay, I apologize. I noticed there's a bit of an issue with one of the links on the left-hand side here. So what we're going to do, we'll just send you an email with the links, both of these links, both with the materials and recordings. I'll do that right now, okay? That way you can access. We've uploaded a number of the presentations already, so you'll be able to follow along with us if you want to access any of those. And of course, if you want to access them after the conference, we'll make sure to upload the material there. Same with the picture link. If you're not able to access it through the QR code, we'll also share that both those links in an email right now, and then you can just open those up. You can upload pictures, any of the pictures that we take, including our group photos or any of the other professional photography. That'll be uploaded there, and you'll be able to access that as well. Okay, so I apologize if these aren't working for you, but we will share links to your email in about 5 minutes, okay? Thanks.
Good morning again. I would like to, on behalf of HISP Vietnam, I would like to welcome you again to Da Nang City. In Vietnam, all Vietnamese consider Da Nang as like the most deserving city to live. Anyone who travel to Da Nang would like to stay here forever. And Da Nang also have another nickname, is a city of bridge. I hope that from your room in the hotel, you can see to the back side, opposite side of the beach, there are so many bridges everywhere across Han River. So we do hope that along with the conference, you will have a good time to enjoy this most deserving city to live in Vietnam. So I would like to introduce to you some logistic information. Earlier, my colleagues, Anu, already go through the agendas with all the practical information for today, like where is the lunch and where is the dinner. You can go back to the agenda to see some other practical information is that I would like to introduce the outside. We will have a toilet at the end of the entrance. When you get out of the elevator, there will be 3 toilet there for you. And at the tea break, we will have a tea break at the foyer outside here. And before the tea break, I would like to invite all of the participants. We will have a group photos. And the lunch will be served as a buffet at the third floor, one floor down here. And after the conference today, we would like you to have a welcome gala dinner, which will be organized from 6 p.m. at 25th floor. All the participants, even you live here or live outside of the hotel, will be invited for the gala dinner at 25th floor from 6 p.m. There will be music and dance served there. So I really do hope that you can sing and enjoy the dance with all the participants from all over the world. So then that is some practical information only. I always be here and sit outside there. Many of you would like to make the payment, but this morning I'm very sorry that I'm very busy. We cannot make it. But during 3 days of the conference, feel free to reach me and do the payment, okay? And so now I would like to introduce John. Anu will come back to the stage.
Right, thank you. I'm looking forward to the dinner already. So for our next session, I would like to invite Ula to come up on the stage for our next session. Ula?
Good morning, everyone. So my name is Ola, as Anu introduced. I'm working for University of Oslo, the HISP Center, together with Jørn and other colleagues that are here. So Jørn gave an excellent review of the whole 30 years history. I'll talk a little bit about how we organized globally in the HISP network at the University of Oslo, and then Sora will talk more about the Asia HISP hub and the Asian groups. So as Jørn mentioned, it started already in 1994. HISP started as a research project. It's now a global big network of 24 HISP groups, really focusing on strengthening health information systems and information systems in general. So we are now called the HISP Center at the University of Oslo. We have about 100 staff there, including many software developers. And as you know, we developed the DHIS2 platform with a team that's distributed across the world, but led from Oslo. The core activities in the HISP network that we support and facilitate is around local innovation, capacity building, and research. And we do this with finance and collaboration from many global health partners. You can see them listed here. I think from the very beginning in 1994, NORAD, the Norwegian Agency for Development, has been our closest partner and been supporting this work, and still are. And then you can see many other partners like Global Fund, PEPFAR, Gavi, CDC, UNICEF, Gates Foundation, USAID, and WHO. And we are also a WHO collaborating center focusing on strengthening health information systems, and work very closely with WHO on a lot of the recommended ways to implement DHIS2, including this metadata toolkits that we'll talk about later at this conference. So when it comes to DHIS adoption and use around the world right now, there are 89 countries where ministries of health have adopted DHIS2 as their platform for their integrated health information system. And more than 30 of these are in this region. So as we can see on the map, these dark green are the ones that have scaled nationally, and then the lighter green, these are countries that have started to scale up or use it at a kind of subnational level. So it's really growing quickly, and it needs a lot of support, a lot of capacity building, and this is where the HISP groups come in. So we've, as I said, we have 24 HISP groups, including the University of Oslo HISP Center. You can see them all listed on the right. There are 7 in this region organized under this Asia hub, and then there are 15 groups in Africa organized as HISP Africa. That was a hub that was actually launched formally last week. I just came from meeting there in Tanzania. And then we also have a group in Latin America. These groups provide DHIS2 expertise, capacity building, technical support and guidance to governments around the world, and of course mainly ministries of health, but also increasingly other sectors like education. What's important about these HISP groups is that they are not project-based or short-term. They are really there to stay and offer a long-term, reliable relationship with the governments they support. As Jørn also mentioned, we do a lot of collaboration with local universities around master level courses, PhD courses, and also in-service trainings. And we still do a lot of research on information system strengthening with a big global PhD program with many PhD students from Asia and Africa. A key part of the HISP group approach is to innovate locally, solving local problems, and then to share these innovations with other groups, with other countries, so that we have a very collaborative network. And this network, just like the DHIS2 platform, is supported and funded by many of these global partners that are listed here. And of course, these partners are very active in funding health information system strengthening at country level. But it can sometimes happen in a bit of a fragmented way. So that's, of course, a known challenge. And I think by working with the HISP groups can help to do this in a more coordinated way when it comes to the DHIS2 projects in countries, and try to align them so that we can all together strengthen the same system and an integrated approach to DHIS2 implementation. What we are seeing is that HISP groups now have become more than just a technical partner for DHIS2. They provide a lot of support on the broader kind of digital transformation processes with governments, and also increasingly support also other tools than the DHIS2 itself. So this is a growing network, both in number of groups and in their capacity to support their governments. So we have a bit of a signing ceremony to do today. We have this year revised the MOU for the HISP network. So all the 24 groups will sign onto the same document, adhering to these values that are listed here, and also some principles for how we operate. So I was in Tanzania last week with 15 groups in Africa. They all signed. And today, the 7 groups in Asia will sign on to the same document. So as you can see, these values are really about collaboration and sharing. As Jørn also talked about, that journey over 30 years has been a very collaborative process and focused on sharing what we learn by solving problems in one country, in one district, are shared with the global community, with other groups, with other countries, so that we can move together and innovate together. Of course, we promote open source solutions. The DHIS platform is completely open source. It's quite generic, but we try to keep developing that platform, enhancing it, with local users in mind. So through collaboration with the HISP groups, with all of you in the governments, we try to have a local participatory design process where we can learn your requirements, your specific needs, and turn them into generic features that we can release on the DHIS2 platform through a kind of participatory design process that Jørn also talked about. Through that and all the capacity building in country, we really want to foster and enable local ownership so that governments can take full control and have capacity to maintain and further develop their DHIS2 system in country. And that's where this long-term relationship with the HISP also come in, that they are committed to be there and support you and gradually build capacity so that you have that local ownership. Yes, so I think, as I mentioned, we'll sign the MOU today. So before Saurabh talks about the Asia Hub activities, I'd like all the Asian groups to come on stage and we can quickly sign this document. You can see the signatures from Africa on the right. And here are the values and the principles that we are now signing on to. So we'll do a bit of a signing here and take some photos, and then we move on with the agenda. Thank you.
Yeah, actually, I would like to invite all the HISP leads to come on the stage. Okay, so we start from HISP Bangladesh, Mr. Hanan Khan. Yeah, photo is there. Yeah. Okay. Next, pose for the camera and stand there. Please stand there. Okay. Next, HISP Pakistan. Mr. Adnan? Yes, just stay there, stay there. We'll have a group photo together. Yeah? Photo? Okay, next, our new member, HISP Mina. Mr. Muhammad. Then I request HISP Sri Lanka to come. But before that one, Muhammad Fos. Okay. HISP Sri Lanka, Mr. Pamod. And then like we have Mr. Saurabh from HISP India. Then it's me, John Lewis from HISP Vietnam. And we have HISP Indonesia, Ms. Rati. So these are all our HISP Asia team. Right, from all the people. So if you are working together, we always work together and like make sure that we always aim to work together and collaborate in implementing joint projects between different countries, help each other in different places, because like each and every group has their own strength and also weaknesses, but like, with a collaborative effort, we have very strong team. So we work together across. So we have all the people around here. Last year we were in Sri Lanka. So next year maybe we'll be in Indonesia. So this conference will keep on moving based on where we want to try to organize. Yep, Saurabh? You can tell about the secretary.
Okay, so I have the presentation. Okay. So yeah, so as John mentioned, we all work in a collaborative manner. So we are 7 HIS groups, and HIS India acts as a secretariat, taking care of the administrative responsibilities of managing the hub. So I have a quick slide deck to show the updates and the projects that we're working together. So you'll get to know how we are coordinating and supporting multiple countries in the Asia region for different initiatives.
Thank you.
So as we just mentioned, HIS Asia Hub is a body which comprises of 7 HIS groups in Bangladesh, India, Indonesia, Middle East and North Africa, Pakistan, Sri Lanka and Vietnam. We jointly work together to support the customization and adaptation of DHIS2 to meet the specific needs of the countries in the Asia-Pacific region. We have been working on building capacity and technical support to the government health agencies and the partners on DHIS2 implementation and usage. And we are supporting the integration of DHIS2 with other information systems to enhance the interoperability and data exchange in the countries we work for. So the objectives of setting up the HIS Asia Hub was to create a formal network to support the HIS groups in the region for technical and administrative areas, promoting coordination and cooperation activities related to information system strengthening at the country and the regional level, building better collaborations with funding partners in the region, building more cohesive DHIS implementations and support plan for the countries we work in, building shared expertise on DHIS implementation areas such as HMIS needs assessment, country HMIS work planning, budgeting, DHIS technical assistance and implementation support. We ensure that we work together to give quality delivery of DHIS services in the region, and most importantly, collaborating and working together to share best practices and encourage skill transfer between the HIS groups and the ministries that we support through improved administrative performance and organizational development. Just quick highlights of some of the joint projects that we have done over the last couple of years. So we finished the Global Fund Data SI project at the end of last year, where the HIS groups in the region worked together in supporting 6 countries for various DHIS2 technical assistance projects in Afghanistan, Myanmar, Sri Lanka, Pakistan, Bhutan, and Nepal. In total, through 3 years of the project, we were able to accomplish 18 support activities in 7 countries in the region, which included activities like DHIS2 version upgradations, capacity building workshops, implementation of WHO, HIV, TB, malaria dashboards, and we also piloted the health facility profile in a couple of countries. The Global Fund was generous enough to support the last 2 Asia conferences in Vietnam and Sri Lanka, and they were conducted through their support. We also collaborated with UNFPA, the Asia Pacific Regional Office, where we carried out 7 in-country assessments in Nepal, Maldives, Indonesia, Timor, Bangladesh, Laos, and PNG, understanding their current data collection and data use needs, practices for SRM and CH. And we also organized a webinar series for the UNFPA and the Minister of Health colleagues on DHIS2 analytics, data quality, and data use. And to end this engagement, we organized a DHIS2 data analytics and data quality workshop for Minister of Health and UNFPA staff from 6 countries at the end of last year. These are some of the projects that we're working on currently. We're supporting 6 countries in the region, in the Asia region, working with WHO CERO, and HIS India, HIS Vietnam, HIS Sri Lanka, and HIS Bangladesh are working together to support these countries. We recently collaborated with the Swiss TPH, HIS India, and HIS Vietnam and Indonesia to carry out a communicable disease surveillance systems assessment in 3 countries in the region. That is an ongoing project. HIS Vietnam is leading the development of the ICD-11 mobility reporting app, which is a generic application, could be used by all the countries in the region. So currently that's an ongoing development. And recently, last week, the team from HISP India and Vietnam were in Laos to carry out the DHIS2 maturity assessment. And currently we are analyzing the data which has been collected and will soon submit a report to the Ministry of Health and the WHO team. So these were quick updates on the projects that we're working on. Each year, as part of the conference, we also organize the annual HISP Asia Hub meetup. So this year, the annual meetup is on 4th and 5th of October, where we are plan on discussing the work that each of the HIS groups did last year. What were the successes, what were the failures, and what was the lessons learned. Each of the HIS groups will share the local innovations that they've done and how these innovations could be implemented in other countries in the region with minimal modifications. We aim to identify common priorities across the countries and the challenges that the countries are facing with respect to their DHIS2 implementations and work together to find better solutions for them. And as always, we work towards building joint collaboration support, which can benefit the DHIS2 implementation in the country. So this was a quick plan on the annual meetup that is planned after the conference. So that was a quick update on the activities that the HISP Asia Hub has done over the last couple of years and what are planned next. And if there are any questions for any of the HISP groups, they are available for discussions during the coffee break and the lunch breaks. So thank you, everyone, and we look forward to continued successful sessions. Thank you.
We will have a tea break now, but before that, I would like to invite all of you to go to the foyer for group meeting, please. We go outside in the reception hall. Thank you. Group photo. Sorry for sleepless many nights.
Hi. Hi. We just wanted, because we have very late confirmation who will participate. We would like to have a small session of the country presentation, UNFPA Afghanistan. Okay. There is in place, not today, maybe tomorrow or the day after. The last day of yeah. Okay. So we'll make very short if there is a time limit. Sure. So yeah, so we will work today and then. So the position will be about what? Yes, it's how we have implemented the DHIS2. Yes, yeah. Okay, yeah. Okay. UNFPA Afghanistan.
I don't know why it wouldn't work. I would have. But you know, I mean, you know how we nearly didn't.
All right, I hope all the participants is back from the tea break. So for this session, I would like to invite my HIPS Asia team to come up and present on what is new and upcoming features of DHIS2. So I would like to invite Nick on the stage. Nick.
Thanks. So my name is Shurajit Dutta. I work with the University of Oslo. I've met some of you here today. I'm going to be doing this session together with some of my colleagues. So Saurabh, Pamod, Dung, and John will help me go through some of these features. We're going to do this maybe a little bit differently than you've seen previously, where it's not going to be really just talking about what's new necessarily. We're going to be doing a bit of a review of features that are there, and hopefully from this you get an idea or sense of what might be useful to you if you weren't aware that it was there already. So rather than just focus on new features in the latest release, we're going to do a bit of a review in terms of just talking about DHIS2 functionality as a whole. So I'll start with a bit of an overview on the release cycle itself, just to give you an understanding of how we release DHIS2 versions and how you can apply updates. And then I'll cover the new Capture app, and I'll discuss this in a little bit of detail, just to give you a sense of what it is, and I'll also discuss some supporting information that can help you use this new application. I'll then hand it over to Pamod and Saurabh, who will talk about analytics. And like I said, they're not going to really just focus on new features, though they will discuss that, of course. But it's going to be a bit of a review of some of the features that are available inside of DHIS2. We do have a dedicated session on the analytics features in DHIS2, so I also encourage you to attend that if that is something you're interested in as well. And then on the extensibility side, we'll have John and Dung present, and they'll talk about some of the innovations that can be built upon the platform that's already existing. Okay, so real quickly, just to understand the DHIS2 releases and how you can update your own systems. So right now, we have a DHIS2 version 41, and that is our latest version, okay? And all of our kind of release information depends on kind of the version that we're supporting in terms of which versions we subsequently support in terms of the older ones that are out there. We also have a roadmap available, and I'll open that in a second, that goes over the various features that are available in each release. Now, this can be a little challenging to interpret, only because you only see stuff for the latest release. And like I said, sometimes you have momentum building towards a particular feature, and you want to see kind of all the different features and different kind of uses of that that have been built over time, and there might be some need to look at past release notes as well, for example. Okay, so we release a new version of DHIS2 once per year now, okay? So we've just released version 41, I think, in May of this year. Okay, so you'll see version 2 about a year from then. So there is some time now between the upgrades, and this is meant to give you a bit of time to kind of work through the features. And some of you yourself, you know, you may not even be on this version, and that's something we understand, and that's completely okay. You know, maybe you're on 39 or 38 or, you know, whatever it is that you might be on. We understand that there is some time that it takes in order to implement these upgrades, and we are kind of making sure to support that a bit more. So in addition to the annual releases that are available, we also have what we call patch releases. So the patch releases are meant to address things like maybe bugs or implement maybe small features that are not going to be kind of, or required to implement a whole version, full version upgrade for, you know, in there. And the patch releases support the current version plus the last 2 versions. So right now we're on version 41, so you'll see patches for version 39 as well as version 40 released in addition to version 41, okay? So if you're on 38, you won't see any new patches. That doesn't mean it's, you know, not a useful version necessarily, but there won't be any security updates or bug fixes applied to that particular version, okay? So that is the model we currently operate under in terms of our releases. Okay, so I've linked to this roadmap in the presentation so you can kind of get a sense of what the features are, both in the latest releases as well as upcoming releases. So version 41 was released in May, and you'll see kind of all these different features that are available split by these different kind of products, let's call them. And if I scroll down a bit past this, I'll also see for version 42, which is scheduled a year from now, some of the features that are available there. You can also use this tool called Jira to follow some of this, but it's a little kind of difficult, I think, for the average person to use. So it's a little bit easier when you just see this as a list tabulated on the web page. Okay, so in addition to the annual release cycle and our patch releases, we also have a kind of relatively new concept for DHIS2 at least. Okay, so apologies for that. So a relatively new concept, at least for DHIS2, and what we refer to as a continuous release. Okay, so we know it's quite difficult to upgrade your entire system from one version to the next, right? Let's say you're on version 38 and you want to move to version 40. There's a lot of testing, a lot of time, a lot of effort that is needed to move to that version, right? Could be localization issues, whatever it might be. Okay? So under this continuous release model, you're able to update some of the apps that are available. Okay, so under this continuous release model, you're able to update some of the applications inside of DHIS2 without upgrading your whole system. Okay, so for example, let's say a new version of the Maps app is released and you want those new features, you don't necessarily need to upgrade your entire DHIS2 system. So this could, in essence, save you quite a bit of time and gain you access to some of the latest features, but without having to kind of plan around this annual release cycle. So if you are relatively up to date and you're happy with that version, but you just want some of the latest features that are available in some of these applications, then you're able to update those and stick with the version you're on currently. Okay, so this is an example. Sorry, it's pretty small. Okay. This is an example of one of these applications that is available via the continuous release cycle, okay? And this is the Capture app. This is one of the apps that I'm going to demonstrate in a moment. Okay, and you can see there's all kinds of various versions that have been released. And there are kind of small fixes, both small and large fixes, I should say, applied within these releases. And, you know, because of this, you know, let's say I'm on version 40, for example, and I don't want to upgrade to 41, but I want to update my Capture app. Okay, then I can do that using this model. Okay, so I'm just able to install the latest version, for example, or upgrade or update whichever version I have currently, and that'll update the version I have in my system with the latest features without having to upgrade the entire DHIS2 software. Okay. Okay, so those are the two kind of release cycles we work under. We have an annual release of our software every year. We also have these patch releases, which are for bug fixing and things like that. And then we also have this continuous release cycle. Apologies. We also have this continuous release cycle that allows us to update the apps within our DHIS2 system. Okay, so what I'd like to do now is get into some of the features that are inside of DHIS2. So one of the updates we have recently is a new login application. You'll see this just in the latest version of DHIS2. So version 41, and there's some custom layouts for the login page that you can kind of provide. It looks a little bit different than before, but maybe more interesting are custom layouts that you can kind of add in to the login screen. So here's some examples that you can create. either using what's built into DHIS2 or through your own customizations. Here's another example. So if you want to switch up kind of what's on your login screen from that regular blue page, there are some features in order to do so. Okay? Okay, so the bulk of what I'm going to talk about with you today is the new Capture app. Okay? So I'm not going to just focus on the new features of the app because maybe some of you haven't seen it before, maybe some of you have. Okay, but I just want to give a bit of an introduction to this application and discuss a little bit in terms of how you might transition to this application if you are using Tracker Capture currently. So there are some caveats to this new app. So as of version 41, this app has now the same features as Tracker Capture, plus many other new features as well. Okay, so and basically anything you could do in Tracker Capture, you can also now do in the Capture app. But the interface is quite a bit different. And there are also a number of new features on top of this. So this might make it a little kind of confusing to new users if they're really used to using Tracker Capture in the regular workflow. So we are trying to help with this. Okay. And I'm going to go over the app in a moment. But we will be releasing this in a month or so, maybe when I'm done traveling here, basically. And we're making this kind of toolkit in order to assist you in moving from Tracker Capture over to Capture. And within this toolkit, we're basically listing all the different kind of features, where things were in Tracker Capture, and where they are now in the Capture app. So this will hopefully help. We will also have a training package and everything, along with some videos, etc., going through the features. So the whole idea is to kind of help people along in terms of identifying, well, if I did a referral in Tracker Capture, how do I do it now in Capture? When I used to register someone in Capture, or in Tracker Capture, how do I do that now in Capture? So all the kind of features that we were kind of familiar with are discussed in this guidance, as well as some additional features that are there now only in Capture, as Capture has some extra features that aren't available in Tracker Capture. Okay? So some of you might be, depending on where you are in your implementation, maybe you've never even seen Tracker Capture, maybe you've only used Capture, that's fine. Maybe you're kind of thinking about how you move forward with this. Okay, so all right, so this is the Capture screen. So if you aren't familiar with this app or have never seen it before, this is what it looks like. So it looks a little bit different than Tracker Capture. So there's no more of that org unit hierarchy on the left-hand side. You don't have separate program selectors that are static at the top. Now you have different selectors and a bit of a different interface available. So instead of kind of working through that regular workflow that you had, if you were used to that, now we see that there's a bunch of selectors at the top, and they kind of remain permanently. So I can select my program, my organization units, etc., at the top of the screen, rather than at the left-hand side. Okay, and those remain there regardless of where I am in the Capture application. You'll also see the front page list. It looks a little bit different than it used to before, and there's a number of new features that have been added to this front page list. Also, the buttons for search and creating a new tracked entity are up at the top. You'll also notice that the labels have been changed, or maybe you haven't noticed. But if I'm making a person, then it'll say I'm making a person. If I'm making some type of commodity, it'll say commodity, rather than just saying, create a new TEI or register. Okay, the language has changed a bit depending on the configuration. Okay, so there is a little bit more customization that can occur to make it easier for the user. In addition to what we see on the screen, we also have a lot of features for what we call working lists to alter this front page screen. So I've added a couple here, and I'll discuss those in a moment. But what these working lists allow you to do, basically, is filter out that front page list and give you quick access to the individuals, let's say, if you're working with people, very quickly. So if I want to just see, in this case, I'm working with this case-based surveillance program. Let's say I just want to filter out all the cases with meningitis. I could do that very quickly, rather than having to set something up manually. Okay, so for example here, I have this little widget here, and it's hard to see on the screen, and I'll try to zoom in. Okay, but it says active enrollments with meningitis. And if I just click on that, it'll just update my list. Okay. Oh. Okay. And now it'll just show me those cases with meningitis really quickly. And I'm able to quickly save these views, create them on my own. If I clear this, for example. So I could say active, and I could say here, meningitis. Okay. And I'm able to then save these views for myself and share them with others as well. Okay, so before in the past, if I wanted to modify this working list, it was a little challenging, but now I'm able to create these filters for the front page list very quickly and save them for my own needs and purposes. Okay. As part of the Capture app as well, here I'll just get in, before I get into that, I'll just cover a bit more on the interface. Okay, so if I just open up a case, you'll see a new kind of dashboard layout as well. Okay, so if you were used to the old dashboard, there are a lot of familiar items. They're just maybe in a different place than you're used to. Okay, so you'll see, for example, that the data entry portion of the application is separated or segmented a little bit differently than it used to be, right? Before we had a couple different options. We had this tabular option, and we had this timeline option, which was just linear kind of boxes of all your various events in your program. Okay, now what we have are the stages. So we have what we call a widget here, and it's the stages and events widget that houses all the different data entry for your program. So we have the different program stages, and they group all your events together. And if I scroll down here, this is a surveillance program with a couple different stages, and I'll see within those stages all the different events that have been entered. Okay? So if I have some stages, let's say with repeated events, I'll see those repeated events grouped together underneath that particular stage. Okay? So the nice thing about this, of course, is you can also just really quickly get an overview of what's in your program as well. Oh, I've closed the whole thing. Okay, so this is just a list of all my program stages. It tells me how many events I have. It tells me when they were updated, etc. Okay? Now on the right-hand side of the screen, this is where all kind of the different pieces of information you could have in the Tracker Capture app are now placed. So for example, you have the person profile as a kind of widget or box on that right-hand side of the screen. You know, it used to be up here and here, right? You had the enrollment organization unit and some other information, okay? But you'll see here that this bar persists at the top. So we do see, for example, which organization unit they're registered in, the name of the person, their enrollment date, etc. And you can add more parameters actually at this, for this top bar as well, okay? But then some of the other items have been moved around, like the profile, it's here. And you can alter this layout. It's in a different place now, however, okay? So you do this through something we call the data store. I'm not going to talk about that too much right now, but just know that you can alter the layout of this tracked entity dashboard if you would like to see things in a different spot or in a different place and share that with other users. There is some more information here. For example, I'll just get out of this person. Okay. So we have some other additional enhancements. Okay, there's a kind of enhanced change log, we call it now, instead. So this is the previous audit log. So if you want to see what's been changed or updated within a particular event and keep track of all that information, you are able to do so. And this is a bit improved from how it was placed previously with all the various updates that a user has made to a particular event within a program stage. And then some of the features that you would have been used to, like creating relationships, making transfers or referrals, those are also available within the new Capture app. So for example, if I wanted to make a relationship, I can do that from the relationship sidebar. You'll see, however, the interfaces are a little bit different, right? So if you're not completely familiar with how this looks right now, I wouldn't worry about it too much. Like I said, we do have a nice piece of documentation coming out very soon that explains all of these differences in quite a bit of detail. Okay? But same thing as before. When I create my relationships, I can add a new person and create that relationship, or search for an existing person and use them to create my relationship. Okay. I'm also able to make referrals and transfers just like before. So if you were using, I think in version 40, I don't believe you were able to do this in the Capture app, but as of version 41, you are able to do so. So for example, if I wanted to make a new event and have a one-time referral, let's call it, okay, in a different place. Okay, I can do that. You'll see it's registering this event in this organization unit one time. Okay, the other thing I can do, I can also assign events to users. This is something you could do in Tracker Capture as well, but was a bit underutilized. So I'm just going to kind of explain what this does. Okay, and I'll go ahead and schedule this in this org unit. Okay, and we'll see here that this person, they're registered in one organization unit up at the top. Oh, it's not showing my cursor anymore. Why is it not doing that? Okay, so this person was registered in one organization unit, Fang Sali, but they have an event here scheduled in this other organization unit here. And this is just a one-time referral for that particular event. It's not transferring the whole tracked entity. Okay? We can also transfer the whole tracked entity if we want to. That's done through a different location. Now we have this enrollment actions button. Okay, it's a bit hard to see on the screen. Hopefully it's better on your computer if you're looking there. Okay? And that's in this enrollment widget. There's a number of actions that we can do. We can complete the event, mark for follow-up, transfer. We can also delete the event. I think one thing that's important to note, that's really important probably for a lot of you, in the Capture app, you can now decide who deletes events or tracked entities. Okay? Before, in the Tracker Capture app, it was either all or none. If they had access to the record, they could modify that record and they could delete that record. Okay? But now you are able to provide specific user permissions that allow you to control whether or not they delete this record. Okay? So for example, if someone doesn't have the authority to delete, then they won't even see that delete option there any longer. Okay, so hopefully that'll help some of you out who've been requesting this feature. Okay, so if I want to perform a permanent transfer, I can also do this by clicking on the transfer button. Okay, so for example, let's see, I'll keep it within the same district. Okay, so I could transfer this, and it's going to take that entire kind of record and then transfer it over to this new location. So I'll go ahead and do that. Okay. And we can see it gets updated. So this is where I started. Okay, so this is where it was registered initially, but now the entire record has been transferred to a new organization unit, okay? So we'll keep track of that history as well within that record. So if you are doing some type of transfer for any reasoning, it will keep a record of where those people are coming from. Okay, so real quickly, just to also just expand on when I assigned a event to my user, what you can do with that. So I've created another filter here, active enrollments assigned to me. Okay, and what this does, it just filters from the list any kind of event that's outstanding that has been assigned to my user. So for example, if I just want someone to see a quick working list of the individuals they need to follow up on quickly, I can do that if I've used this assign functionality. Okay? And this is an event that's, you know, maybe assigned in the future at some point in time, but the person can just log in and see, okay, today, which events or which people should I be dealing with, and work through that list one by one until they've completed all the records they're supposed to be handling, as an example. Okay? So there are a number of new features in this application, and of course, the old features that we had from Tracker Capture are here as well. Like I said, we'll be coming out with quite a bit of detailed guidance on this, walking through the features, showing where everything is, explaining the differences between the two applications, as well as all the different upgrades and updates that are there for the new application. Okay, one other thing that's been added that I didn't get a chance to show is the ability to select multiple options within one option set. Okay, so some of you that might be quite useful as well in order to do this. This is supported on both the data entry side as well as the analytics side to some extent, though more features are coming to support this in analysis as well. Okay, so that was a quick overview of the tracker, of the capture application. Like I said, there's a lot more information coming out on that application to support you in moving to that new application. If you do have any questions about this, please do let me know. I think one thing what might be important to note for many of you is that the previous kind of, the API for that old tracker capture app, it's not really being actively supported. And any updates to tracker capture have also been halted. So if you are kind of heavily invested in that application right now, it might make sense to think about transitioning to this in some time. It's not something immediate, you know, and we understand that it can take a little bit of time to do so. But you know, you have some years even to plan for this. But it's a good thing to think about if you are using that tracker capture app right now, only because it's not really supported that well. And if you run into major problems within your implementations, chances are there's not going to be a lot of support to update that application. Okay? So I'm going to hand it over to the analytics team, over to Pamod and Saurabh, and they'll continue with the presentation.
Right, so we have many data capture systems in all the countries that we work, right? So there are like custom-made data capture systems, but one feature in DHIS2 that really stands out and which many other systems that you have in your country do not support is this analytics, right? We have many countries where they prefer to use DHIS2 mainly because of this, because we have some rich analytics which are supported out of the box. So in this presentation, we are just going through some of these areas. So under analytics, we will talk briefly about what are the different features we have in DHIS2 in the dashboards, and what new features we have over the last few releases, which support nice visualizations and charts. And we will also see like how pivot tables have been upgraded, the look and feel in the last few releases, as well as maps. Okay, so if you talk about dashboards, we know DHIS2 have flexible, customizable dashboards, right? That means you don't need a developer every time when you want to change something in the dashboards. So in DHIS2, it allows custom sizing and location of different dashboard items. So for example, if I want this map to put it on full screen, that is supported. And when we are configuring, we can configure very easily in which part of the screen each of these visualizations appear. So that way, it's very customizable. And in addition, it also supports rich text. So what we mean by rich text, we can make the text bold, italic, so likewise, we can change the descriptions that appear alongside these visualizations in the dashboards. And as I mentioned before, we can change the sizes and the location where it is appearing in the dashboards. And as you can see here, this is where we kind of have, unfortunately you can't see the text, but what I wanted to highlight is like in the dashboard itself, we can visualize the descriptions. Because when we are conducting data review meetings, we really need to see not just the visualization, some description about what dashboard item we are looking at, and that is supported. You can see the interpretations, and we can also see the comments in the dashboard itself. And another thing, if you can remember, and if you have used DHIS2 a couple of years back, we just had a static visualization of a particular analysis. Meaning, like, if we have configured the dashboard to show just a map or a chart, that was all that was possible, and we had to go back to the maps application, or maybe like we need to go to the data visualizer to change it. But now, we can quickly flip between like a map or a table or a chart, so that the navigation and visualization, the richness of the visualizations that appear in the DHIS2 dashboards have really increased. Another thing that I wanted to highlight is we all do data review meetings. So good old days, when we wanted to conduct data review meetings, that means the national team has to physically go from district to district, go to the health centers, look at their data. But now this has been made so much easier by using DHIS2 dashboards. So whenever we want to do desk reviews, we can easily use DHIS2 dashboards because it supports different filtering options. So what it means is that, as you can see here, so when we log in to the system as a national level user, what the data and, that you see in the dashboards are at national level, right? So if you want to drill down, right? So we start with national level and we locate some issue in a particular province, and we want to see like where exactly or which health facility or which district is having this issue. So whenever we want to do that, we can use this filtering. So meaning we can drill down to different levels in our organization unit hierarchy. And also, if we want to kind of focus the visualizations in the dashboard for a particular period, that is also supported. So this is what we mean by adding filters into the existing dashboards. And also, in most of our DHIS2 instances, we just don't have one dashboard, we have many dashboards, right? So when we have so many dashboards, if we are only focusing on mostly on one or two dashboards, which are our favorites, we can make them favorites by clicking on this star icon that you have, so that they appear right at the top. So it's very easy to position those few dashboards if we have a list of, like, say, for example, 10 or 15 dashboard items. And also, we have some improved navigation menu for managing the dashboard items as well. Another feature which has been highly requested is the ability for printing the dashboards, because still in most of the countries that we operate, we have a practice of sharing the data, or rather information, in printed format. So DHIS2 dashboards support printing of dashboard items. We can configure like which way we want it. Is it like each dashboard item per page, or as how it appears in the screen itself, like this. Okay. Another request that we usually get from program managers mostly, or administrators, is that they want to see and visualize data on the move, right? So when you are not at office and you don't have time to sit in front of a laptop or a computer to see the dashboards, is DHIS2 supporting visualizations on mobile. So even though we still don't have a native app for visualizations, we really support the look and feel of the dashboards when we log in using a mobile device. So if you can use our web browser in the mobile device, you can see, like, when you, like, because we have different screen sizes, so the dashboards are now adaptable to the different screen sizes, both in portrait and landscape orientations. Another challenge that we have in especially in the rural areas or health facilities is sometimes when you have these highly rich as in like very many visualizations, some advanced analytics and all, it takes a lot of time for the data to load. So the visualizations keep on loading. So one feature that we have now is the DHIS2 support for offline saving of the dashboard items. So as you can see here, when it is saved, you can easily visualize it, and especially when you are doing presentations in, say, districts or health facilities, it's a really useful feature. So when you are configuring the DHIS2 dashboards, as some of you are, another challenge that we have is that how are we going to configure the dashboard items in a way where only the appropriate or the users who have the permissions are seeing these dashboard items. So a particular feature that we have in DHIS2 to restrict who sees what is the sharing settings. So from a configuration perspective, it has been a real challenge for us to configure the sharing settings for each and every visualization item that you have on DHIS2 dashboards. So now we have this feature where cascading, meaning like we can, as a bulk operation, configure who's having access to all the different visualizations in one dashboard that you see. So that's been made very easy. So something for most of the people who are configuring and implementers to feel happy about. And also, when we are configuring DHIS2 dashboards, we have different ways of configuring the layout, as you can see here, whether it is going to be free flow or fixed columns. we can configure it in such a way so that when you drop an item onto the DHIS2 dashboard, it gets automatically arranged. Right, so let's also focus on some of the features that we have incorporated in last few releases in Data Visualizer. So this new look and feel of this Visualizer app has been there for several versions. So it was introduced into 2.31. And we have a new user interface for selecting different chart types, as you can see right at the top. And then we have the different dimensions, right, which are appearing on the left side and at the top. So this has been the standard layout of the Visualizer app over last 10 releases. And this has been persisting. So, okay. And around the COVID pandemic, we had some new chart requests coming over and over again. So one was, of course, like what you can see here, this gauge charts as well as this single value chart. So in initial versions, when we introduced this feature, they were static values, meaning like you had the value and there were no colors and all. So the support that we have right now for the gauge charts, we have ability to include legends as well as target lines, as you can see here. And also for the single value charts, it supports applying different colors or legends, which has been a requested feature. And also for the bar and column charts, it now supports the application of legends so that you can have a better visualization. So just by looking at it, we will get an idea whether the values are in a kind of, at which scale in a data range. Again, even though we still don't have the specific feature that you are requesting to select individual colors for different lines and all, we support application of color sets into charts as well as styling. Styling means like when you have labels in the charts, they can appear in different colors, or we can make it bold, italic, likewise. Okay. Right. Especially when you are HMIS officer or someone who has access to a lot of different programs in DHIS2, it may be a bit confusing because because we have access to so many different programs in a DHIS2 instance, and each of these programs will have different disaggregations. For example, because we are using different dimensions. So these dimensions can be something like, it could be group, like maybe the ownership or the gender, likewise. So one challenge we had a couple of versions back is we are not really sure which dimension is going to be appropriate for a particular visualization. Now we have this feature which was introduced few versions back, where it highlights what are the applicable dimensions that we can use this use with this particular visualization. So that has been a really nice feature. So for some people who have access to a lot of different programs and not really sure which dimension we have been using for different programs. And also, something cool we have, we introduced a couple of versions back. I know, like, how many of you are using social media? It could be Facebook or Instagram or even YouTube. The thing is, like, how people keep interacting with these platforms is like you always get alerts and notifications when someone interacted with something that we like. It is like, for example, in Facebook, it could be a photo that I posted, and I want to see like how many have interacted, commented, liked. So we also have something similar in DHIS2 to promote the data use, right? So the challenge that we have in DHIS2, even though we create these vivid, really nice dashboards, it just becomes a landing page for most people because, by default, when people are using DHIS2 for years, it's just a landing page. Just like the login page, people just go there and then move to something else, maybe data entry. But now we have these features where, for example, you can see the bell icon here, right? Like the subscribe, where like when someone subscribe to that particular visualization, you always get alerts when you log into the DHIS2 instance if something, a new interaction has happened. So it could be a comment or something like that. And even when it comes to these interpretations or the descriptions, people can tag other people. So for example, if I'm the HMIS officer and I want to know and I notice some issue with a particular visualization, and I want to get a comment from the health facility staff, I can always put a mark at and then the user, so that user will get an alert that somebody has, somebody is wanting some kind of update from me regarding a particular visualization. So these kind of new features really promote the data use and the engagement, and to kind of promote data for action. So these features have been incorporated in last few releases. Another different chart type that we have introduced to support, for example, use cases related to surveillance and things like that, where we wanted to compare data over a couple of years, like what happened at same period, or maybe like what happened in months of April and May over last 3-4 years. To have that kind of visualization, we have this, we introduced this new chart type called year over year, both bar and line charts, as well as, that has been there. And also, together to support the same kind of visualizations, we now have the single value charts. So we can have year over year charts as well as single value charts, so that certain things can be highlighted in a very precise manner. And DHIS2 now supports multiple axes. So as you can see here, it's not our simple x and y, one single x-axis and one single y-axis, but here we have more than one y-axis. So for example, here we have one axis, right? The range is different to what we have on this side. So meaning, when we want to visualize something very complex, we can use these advanced features where we can actually create it's very descriptive. But the caveat is that when you are having these kind of dashboard items in your dashboards, just be mindful of who's actually seeing this data. Because if it is for a very simple health facility staff, if they don't have proper training, these kind of charts may not be so meaningful. But for many people and statisticians, this will give a really good idea about different ways of comparing data with different data ranges. And in addition, you can see here, we have two categories. So the x-axis here are the months, and then here at the top, we have separate categories for urban and rural. I'm sorry for the not so nice visibility for the people at the back, but what I wanted to highlight is these two categories, what you have at the bottom and what you have at the top are different. And another feature which is really new is this scatter plot. So some of you may have used the WHO DQ app. So one reason why we wanted to use like WHO DQ app, data quality app, is the support that it has to identify outliers. Because these scatter plots are a nice visualization where we kind of look at it, and at a glance we will be able to see the outliers. So again, like I don't want to go into details about like what scatter plots are, but in very simple terms, what you can see here are two related data elements or indicators, right? So when you have two related data items, and we want to see, for example, like we want to, each of these dots could be different organization units. So if you want to see like what are the organization units which are having outliers, right? It could be plus or minus 2 standard deviations. We can nicely visualize it in this kind of scatter plots. So this is a really new feature, and I encourage you all to try them out. Right, so now that we are done with the data visualizer, let's look at like what are the different enhancements we have related to the tables. So over to you, Saurabh.
Right, thanks, Pramod. So for the next set of slides, I'll review the new features and the enhancements done in the pivot tables, as well as the maps application. So pivot tables, as we understand, has been added as an additional visualization in the data visualizer app from version 2.34 onwards. And the previous pivot table app is no longer available from version 2.37 onwards, and all the functionalities and features of the pivot tables app have been migrated to the data visualizer app, which becomes your one single app for both charting as well as tabular needs. So in the DHIS2 instances, all the previous favorites which were made using the old pivot tables app, they're available in the data visualizer app now. So you can open existing pivot tables in data visualizer app also, and they will perform seamlessly. Similar to the data visualizer, the improvements have been carried forward to the pivot tables chart type as well. So you could see the persistent layout of the items quickly here on the top. So you can switch between these items, between the data period and the additional dimensions that you've added. And in addition, you'll see these green dots next to your dimensions. So the system tries to give you some clues in which what additional dimensions can be used based on the data models in which the data is getting collected. So for example, if I'm looking at the rotavirus 2 doses given for the facility, then I can see some green dots against the age, the type, and the urban-rural dimensions, which could be further added, and the data can be disaggregated by those data dimensions as well. In addition, there have been new improvements which have been introduced, where you can freeze the column and row headers so that you can visualize and navigate the tables easily, especially when you have large amounts of data in the tables. So you can freeze the rows and columns similar to what you can do in Excel files, and then you can visualize the data and navigate it a bit comfortably. For the Maps application, there was new Maps app introduced in version 2.29, which has a completely new interface for adding new map layers. And moving forward, there were new map layers were also introduced, which I'll cover in my next set of slides. So from version 2.41 onwards, you have a new setup for downloading the maps as images, where you can choose different options which you want to show on the map download, the image download, such as you can show the description, you can show the map name, you can see the overview map and the north arrow, and then you can choose which side you want the legends to be shown on the image. So on the right-hand side, you'll see the map name, the description if you want to show that, and the legends. And this similar image will get downloaded, which will have much more information as compared to the previous versions. In addition, now you can also download the layer data for the maps that you're trying to create, and that layer data could be then imported into external GIS applications such as ArcGIS, QGIS, and other softwares, which can do much more deeper fine-grained analysis than what is currently supported in the Maps app. So you can export this data and import into external applications and use that for your mapping needs. In addition, you can see the data that you've plotted on the map as a data table. The data table has the data arranged by the levels at which the data has been plotted and the values, and each of these dimensions can be filtered by putting ranges, or if you're looking for a specific district, then you can put the name here and it will filter out the table, as well as the map will also get filtered out and will only focus on the filters that you have added here in the data table. So this is dynamic and can help you to filter data and view it more granularly. In addition, you can now add data dimensions to filter your maps. So for example, if I'm looking at the HIV tests performed and I'm collecting this data by the gender, then you can put the filter dimensions in the maps as well. So your maps will then only show the data for the dimensions or the filters that you've added here, and thereby you can do a separate visualization for, say, male and female people tested for HIV. So you can add more dimensions, and you can use dimensions as filters in the Maps application. In the latest releases, you have the options to create both the choropleth, the heat maps, or the bubble maps. So both the options are available now. So the general recommendation is to use the choropleth maps or heat maps for generating or indicator coverages. While if you're looking at raw data or in terms of volumes and numbers, it is recommended to use the bubble maps so that the differentiation could be seen very clearly in terms of the raw data which is available. In terms of the views which are supported within the Maps app and also on the dashboard, you can see the maps as a split view or a timeline-based visualization. In split view, you will see that the same map will show for all the years that you've selected. So if you want to see the changes in the last 5 years for the same indicator, then you can use a split view, which will split the same map into n number of periods that you've selected for analysis. Or you could also do a timeline view where it will run as a dynamic visualization, which will keep running and switching to each year, and you can visualize the change from one year to another or the periods that you've chosen for analysis. So both these views can be done within the Maps app, and they're also supported on the dashboard as well. So some new enhancements have been made to introduce organization unit profiles as part of the Maps application, where you can report data against the attributes of the health facility, including the images, and then those profiles can be seen within the Maps app. So it is necessary to have the facility coordinates along with the attribute data for creating organization unit profile. So this is now available from version 40 onwards, and then that could be visualized in the Maps app along with the images and the attributes of that specific health facility. In addition, there have been ongoing integrations with partners such as WorldPop, who have provided their APIs for integrating the population estimates directly into the DHIS2 Maps app. So we have these new layers which have been added, the population and the population age group, which allow you to import data from the WorldPop servers and plot the estimated population data on the maps. So this could be then overlaid with your indicator coverages, etc. So if you don't have accurate denominators for your population, you could use this as a substitute source for getting population data. So you have disaggregations by gender, by age group, which are available and which could be sourced from the WorldPop servers and then can be used on the Maps application. Next, we'll see some of the new features which have been introduced for visualizing the tracker data. So there's a new line listing app which has been introduced, which currently gives you the features for creating your line list reports across enrollments and for repeatable events as well. So this is similar to the user interface which you see for the data visualizer app and allows you to do complete tracked entity analytics. It is compatible from version 2.38 onwards, and this is part of the continuous release process where updates to this app are released more frequently, and then the users can upgrade these applications from the app management in their DHIS2 instances. Using the line listing and the event reports app, which is still supported, you can create aggregated summaries for your tracker data, and you can also create detailed line list reports for your tracker or event programs. For the standard data collection for your option sets or your drop-down menus, using the event visualizer app, you can easily summarize that data and create charts and tables out of it. And all these features which you see for aggregating the tracker data, they will eventually get released as part of the new line listing app. So that will support both line listing as well as aggregate tracker analytics. In terms of creating the indicators, we all understand we can create the indicators using both tracker and aggregate data. So I can create indicators which are using my data sources from my population data set, for example, and then I can use my tracker program or event program as an aggregation for the numerator. So we can see certain examples, for example, the live births which are coming from the community. That is coming through the tracker data, and the BCG doses given is coming through the aggregates, and then you can calculate these coverages by putting these variables into the numerator and denominator. So you can combine multiple sources of data coming from your patient-based or event-based data collection and using denominators from your aggregate data collection. Okay. In addition, in the event report application, you can apply different disaggregations for your raw data. So you can use your data dimensions in which you're collecting the patient data, such as the gender, the age groups, and other properties that you're collecting for that specific person or the event, and then you can quickly aggregate them using the event reports application. So the aggregation features which are available as part of the event reports application, they'll soon be transferred to the line listing app as well. So then it will become the standard reporting tool for your tracker aggregation. Then in the line listing application, you can review the tracker data across multiple program stages. So if I'm trying to create a line list where I want to see the initial TB test result, and then I want to see the treatment given and the outcome of the treatment for each patient, then I can create a consolidated line list where I can collect data from 3 different program stages, which were part of my initial TB diagnosis, the TB treatment initiation, and the TB treatment outcome. So you can create consolidated line list by picking data from multiple program stages or multiple events, and then you can visualize them in the line listing application. There are many programs which require longitudinal tracking of cases, such as HIV. So you can look at the repeatable program stages data updated together for all the respective cases, and you can see all the visits when they made and what were the data collected in each of the visits. So this is also available to review the repeated stage data altogether in the line listing application. The support for maps also extends to tracker data, where you can review the data which is collected in the tracker programs, either through program indicators or indicators, but you can also use the location of the patient and create these clusters of cases. And the locations could be captured in multiple ways. You could have the location of the health facility where the services are being provided, and you can also collect the person's household information or household coordinates to see the clusters and the spread of, say, a particular disease in a respective community or a catchment area. So you can do analysis by both the facilities, the facility level coordinates, as well as the coordinates of the patient's household address. So for continuing the presentation and covering the extensibility part, I'll request John to take over.
Hello? Can you hear me all? With the mic and without the mic, even in the back? It's like we saw like what are all the different features are there inside DHIS2 itself, right? The data entry, the tracker capture, the capture app, and then the data visualizer and all things. So now I just want to focus on what DHIS2 also allow, like both for the programmers and for other things to be developed together. Yeah, how we can try to use DHIS2 or how we can try to extend DHIS2. And followed by me, we have Dung, who will actually show a few of the extensibility, what he has been used to develop it so it can be used in different places, like in Laos and in other countries. Okay, so DHIS2, like it's a platform, right? So like so we know like DHIS2 can be used for mobile and can be used online and all the things, but also it can be extended because of how DHIS2 has been designed or designed and built into it. So we have a very big, or in the core we have a RESTful API and the extension which can be used to either integrate the data between other systems and also try to build an app and which can be installed inside DHIS2. So the end user don't have to feel that, okay, this is a different system I don't want to use. One of the biggest problem what we face when we try to implement any software is we want the end user to feel, oh, this is one system. It's not 2 or 3 different systems. So then like we want to just say, okay, but I want my screen to look exactly like this. And sometimes DHIS to offer as much as possible the flexibility to change, but sometimes you need a different kind of layout by itself, so that like you can meet the end user need, or like to have additional dashboards and all kind of things. So what DHIS2 team have developed is to allow all the developers who knows basic JavaScript and all kind of things to build their own custom app and install into their DHIS2 itself. So when we do an upgrade, like Jan was saying in the morning, that like DHIS2 in Vietnam was hacked. It was not hacked. They actually forked it to make the death accident case. So what they did was they could not meet the user need, so they changed it inside DHIS2. And then we DHIS2 keep on updating, like as Nick presented, every year we release new DHIS2 version. So they could not upgrade the DHIS2 version at all, because like then they have to again like refork it and all kind of things. To solve that problem, what people decided was, okay, let's just give the developers a way so that like they can build the app and install into DHIS2. So when a version is changed from, let's say, 38 to 39 to 40 or 41, so the app will still be useful. So this is one of the way how we are trying to extend DHIS2. So now Nick also presented about continuous release, like for example, app like data visualizer, dashboards, and map. So whenever there is a new update and all things, like you can actually install it or update it in your test instance first, check it, everything is working fine, and then you can also do it in the production one without actually reinstalling the DHIS2. So DHIS2 is a big software, but you can just like update one part of it. So a similar way, this is possible by using the extension one of apps or plugins. So there are a couple of, based on same technologies and the use cases, people have developed multiple apps. The newest one is on the climate app, because we've been working very closely with many of the different climate meteorological department, try to get the Google data or like ERA5 data into DHIS2 itself. Before, like we also like many of the people used app, right? Like which Saurabh had presented in the dashboard in the app. So where you can also integrate with the Google Earth Engine, where you can get all the raster images for your temperature and for your elevation and everything, daylight saving. Similarly, like now, in the climate app, you can also get the prediction of what's happening in the next like 7 days or 14 days for your climate, for your precipitation, and also you can get the data what it was in 1960 and what is there right now. So this is an app which is built on the same extendability way, which you can try to download in your DHIS2. And climate app uses, I guess, 240 or 239, I'm not quite sure, 240, I guess. And anyway, there is a presentation about the climate app tomorrow. You can go through on this one more things. This is just an example of how the DHIS2 extensibility can be happen. And this app was developed by Oslo, but you can try to use the DHIS2 app hub for downloading all this app into your local DHIS2 instance. So in local DHIS2 instance, if it's 40, you can try to do all these things. There are also many other apps which you can try to use that one up. You also have an app on education, logistic, and I'll come back to the growth to health chart a bit later on. But all these things, the features is you don't have to make changes inside DHIS2 or know about the data model or the touch the database. So you can use the API so that like you can build your own app and install it in your own DHIS2 itself. Okay, so this was the 39 onwards. So this was the climate app which we were just like trying to tell about, which you can try to do. And this one, it is not linked to your local weather station, but also from the global one, from the ERA5. Then you can try to actually just see all different kind of things. So where you can just see the weather, the climate, and also the change in the temperature from how it was 10 years back and how it is now. Whether it is hot or cold, or things like it can actually give you all this data. And all this data is not stored in DHIS2. Don't worry about that one. Because most of the time when we just say, oh, all this data is stored, no. This data is directly coming from the cloud, just for your visualization only. The other app what we tried to develop was on the cause of death app, which I guess like today in the afternoon, in one of the parallel session, we are going to demo about cause of death app using ICD-11. So from within the DHIS2, it's an app where you can try to install it. And then you can connect directly to the ICD-11 coding tool so that you can get all the ICD-11 part, plus also underlining cause of death using DHIS. So long time back, what happens, the ICD coders used to write all the things and then click on underlining cause of death. But like now, using the DHIS tool, it is done automatically. So this presentation of things, we have it today, so we can also work on it, how it works. More on the hands-on, this particular part. Okay, the next one is also similar with, this is not talking about MCCOD, but more about inpatient discharge summary. Bangladesh, we are starting based on the Bangladesh requirement. We've been trying to build this app, and also recently it's been used in Laos to try to make IPD discharge summary to be used similar way, so that people can try to install it in your own DHIS2 to focusing on to meet some of the challenges. The how things happened was like we work with different people to try to get more requirement, and we try to build a generic app or in-country app which can be used for our own needs, either by the region or by the country. Okay. This is like app is just like one is the whole app what we try to build again. Then like we also been working very closely with Oslo developer that like they wanted, oh, I have this app, but I want to make a small changes, or I want to include one kind of plugin in the, like say, tracker capture app. So that's also the something which Oslo developer, the tracker team have been working very hard to try to make sure this plugin can be embedded inside DHIS2 app itself. Like for example, like in the data visualizer, you want to have a different chart type or any kind of things, or in tracker capture app, you want to have patient photograph or biometrics, or in this case, it's a dashboard growth to health chart. So this is the growth to health chart which can be included in your capture app. So that like when you have the height and weight, you can get the growth to health chart automatically in the patient dashboard itself. So when the data, when the health worker is using this app, you can try to see the growth to health chart, not only in using the laptop, but also in Android DHIS2 app. This has been embedded in growth health chart. So this is just a few of the example how you can try to use the DHIS extendability by extending, creating your own app, so that like we are not we are actually not reinventing the wheel, but sharing the data to sharing the apps to other people to try to use, and also we can try to use it within the DHIS2 itself. So now what I'll try to do is to ask, sorry? Okay. So I will ask Dung to come around here. So he will give a bit of background about iCapture. This is different. We have capture app, we have tracker capture, now it's called iCapture, which has been used in one of the places. He will give you a bit of background why we are trying to use. Yep.
Hello. Hi. Hello. Hello. Okay. I hope everyone hear me well. So a bit of introduction about me. My name is Dũng. I'm the technical lead of DHIS Vietnam. So and today I'm the first person who using this one. So I'm testing this one. And I will also introduce about iCapture. That's an example on how we can use the custom app to be used in DHIS2. Okay, so about iCapture is as Surajit mentioned before, we have the new capture app in DHIS2. That will be the combination of the event program and the tracker program. So and that will be good if we want some program up and running, easy to use for the people. And when you want some more extension for the capture app, that's when iCapture will be in action. Okay, so iCapture is an app developed by DHIS Vietnam, and it's the combination of the data entry, event capture, and tracker capture. So as we all know, in DHIS2 we have multiple apps to do the data collection. So the first one is data entry. That's we use to enter the data for the data sets. And before that, we have the event capture, what do we use to enter data for the event program. And then we have the tracker capture to enter data for the tracker program. But we already have the new capture app which combine the event capture and the tracker capture. So, but iCapture, that's a combination of everything. So why would we use the iCapture? So there will be no more confusion for the user which data collection app they need to use, because in our experience, for the user, they are very confused about that. For example, if they want to enter some aggregate data which module, which app they use, that can be either data entry or event capture. That makes a lot of confusion for the user. For when we use the iCapture, people can use only one app to do all the data collections. Okay, and for the iCapture, it supports more customized form. So we have more extensions. It can do a lot than the default capture app. And then this that's also support backend service. So what is this one? For example, like we want when we do the communicable disease program. So whenever one cases of severe, let's say severe dengue cases happen in the country, so in iCapture we can do like we will send the notification to the people using the email or via messaging app to notify about the case. So that's one of the example, and it has the better UI and UX. It's more clear, and it also support the localization, fully support localization. Yep. So that's the very quick introduction about iCapture. Now I will do the very interactive demo for all. Everyone can use how it works on the DHIS2. Okay, so on my screen now, I have opened the iCapture on one of our development instance. As you can see here on my right-hand side, there's the icon of iCapture. Okay, so I already opened the iCapture. On the top, you can see that this is the selection that we can select the program or the data sets. In here, for the first one, we have the group, that program. So this is the event program. And then the next one, you can see the second group is data sets. So from here, we can select the data set we want to enter the data for. And on the last one is the tracker programs. So you can see the list of all the tracker programs here. So in this selection, we have data sets, we have event programs, and we have tracker programs, right? So I will try to enter very quickly enter data for one event program called IBD event. One information. This is our development instance of Lao HMS that we are using in Lao. So select the IPD event. This is the event program, and I will select the unit. So all of the units listed here will be filtered based on the assign of unit of that program. So it's like when you select that program, this unit list will be shown only the unit that assigned to that program. Okay, I will quickly select one hospital, and you will see the list of the events. So I will try to register a new case. So this is the event date I put. And you, as you can see here, within iCapture, we can do that the longitude and the latitude, the coordinates of the event will be automatically put. So, and now just very quick. Okay, and down here you can see the current address. What is this? So this one we will select the village that the person come from. So first we select the province, and then we have the province, district, and village. When we select the province, the district will be filtered based on the province that's selected. This is the list of the district that inside the province, and then we select the village. And when we select the village, our iCapture will automatically put the coordinate of that village to that person. Yes, and then we save the record. Okay, so that's what we have for the event program. And then next I will try to one option set. So I've scrolled down a bit, and I will try the OPD version 2. This is a data set. So we will try to enter some aggregate data. So, and then I select the hospital and then the period. Let's say January 2024, and you will see the form. So we can enter some data here. And when you double click on one field, you will see the data element history. And we have comment, we have min, max, and we also have the audit trail. So currently no audit trail yet. So that's how the data set works on iCapture. Okay, now then this is the best part, the tracker program. So in iCapture, we support very highly customized tracker form. I will make one example from Laos. That will be available soon. So in Laos, we have the new set of MCX tracker programs, including delivery registry, including ANC and PNC, including the immunization. Okay, and all of these programs will be linked together. Like when we register a new person in the delivery registry, let's say a mother, and then we can also enroll the same mother to the ANC and PNC program. And when the mother she gives the birth with the list of the children, right? And that children will be automatically created and enrolled to the immunization program. So I will do it now. Okay, let's say first I will scroll down a bit. You have the list of the tracker programs. I will select the delivery registry. That is, and then I will select the facility which the woman will give the birth. And in here, on the top, we have the search button. It says the search from client registry. So in Laos, for all the tracker programs, in the future we will have something called client registry. So what is client registry? This is the list of all the how can I say? All of the clients available in Laos. So first, when you want to enroll anyone to any program, you need to search for that person if they are available in a list. If they are available, then we enroll the person to the program. If they are not available, and we register a new person. Okay. Now let me do a very quick and then move on. First, I will try to search for some model. So it say, sorry, the client cannot be found. So I will register a new one. Okay, I click on register. First, I put the name. Okay, the sex automatically selected as female. We cannot change the sex. Just enter the age and the address. Okay, and click on save. Okay, the model is created. And on your left-hand side, that's the list of the deliveries belong to that model. So currently, because this model is newly created, so we will have one delivery for the model. I will select on that, and then I will input some information for the delivery, for example, date of delivery. And in here we have one field called live births. So if live births, if I enter a number here, for example, I input 1 and I click on save. So there will automatically one tab created on the top. So we have infant 1. So this means this one is the child. So I click on the child, I input the sex, and then I save. Okay, and then the child is saved. And you can see on the bottom right, you have the complete this delivery and the print birth certificate. So when we complete this delivery, the child will be created and enrolled to the immunization program. So I will try it now. I will click on the complete this delivery. First, we need to generate the health ID for the child. And then the child will be enrolled to the EIR program. EIR is the immunization program, right? And then the delivery will be completed. And below that, we have the list of all the children which are created and enrolled. In this case, we have one child with that ID, with that gender and the date of birth. Okay, and I click OK, done. So the child is already created. I copy this one and save it for later, put it here. So I copy the unique ID of the child newly created. I put it here for reference. And then about the birth certificate, so this is the one of the example that iCapture can do, that we can print the birth certificate. We put the information of the child into the birth certificate, and from here people can download these birth certificates or they can print using the printer. Okay, so and then I will go to the immunization program and I will search for that child using the unique ID that we created before, and I search. Yes, the child is available. I will select that child and I will do the immunization. Okay, something happened. But yeah, but from here we can enter the data for the immunization for the child. So I will just introduce about the MCX, the new MCX tracker programs for now. And everything can be done inside only one app, which is iCapture. That's we can link the programs together. So that's a very example of how iCapture will work and why we need the iCapture. Okay, I think that's all for me. Hand over the floor to you, Surajit.
Okay, thank you, Dung, for that presentation. I think that was great. So we have a little bit of time before lunch if there are any outstanding questions. If not, we will have our lunch. So are there any questions? I know that was kind of an overload of information and different information at that, but if there are any questions, we're happy to take them now. So any questions about anything that was presented, or everything clear? Okay, it doesn't look like there are any questions at the moment. If you're more comfortable speaking to us individually, please come and do so. Maybe I'll have Hung explain the lunch. Which? Okay, where is it? I don't even. Third floor? Okay. Yeah, okay. Yeah, I'm just go.
So no more questions? So now we will have a buffet lunch served on the third floor. You can take the elevator down or you can take stay on the hall, okay? So see you in around 5 minutes. Thank you.
Okay, good afternoon, everyone. I think we should start now. I apologize for the delay because some people are still trying to get back to the room, but I think because we have a couple of presentation lined up, and I think we should start. So I hope everyone enjoy lunch and ready to take the next session. So in the afternoon, the first session will be about country presentation on the implementation of DHIS2. So we have 4 countries to present about the implementation of DHIS2. And we will have about 15 to 20 minutes for each country, and then we will have 5 minutes for the Q&A. And I think we should have some time at the end, and then we can have one big Q&A if we have time. Okay, so I think without further ado, I would like to invite Director General Visit Kamlusa from Lao PDR to present about the implementation of DHIS2 in Lao. Yeah.
Good afternoon, everyone. So, just a few people after lunch. My name is Visit Kamlusa, Director of Center for Health Information, Health Statistics and Information. We are responsible about the Lao health information. DHIS2 is the main tool to collect the data for the Lao Ministry of Health. So today I have to present about the 2 main points. One is current ecosystem, and second is further direction. For the current ecosystem, you will see the information of the Ministry of Health. We combine between the health information system is a health management information system on DHIS2. We integrate or we combine into the DHIS2. As I mentioned, is the Ministry of Health in Laos. We use this tool to be the main database of the health information. You will see the data is combined, such as COVID-19, MCH, EPI, nutrition, family planning, and other tuberculosis, malaria, HIV. We can say it's nearly almost the information of the health is we combine together. But you will see the different color in there, like a blue is aggregate. The green event based, the black one is tracker. So we still the meaning is someone is still processing. The outside is the yellow one, even not in the DHIS2, but we still have the owner system to collect the data or information, such as the hospital information system. We have EMR, laboratory, and other health care financing also. We have the system to collect the data. Even human resource for health also, we still have the system to collect the information itself in our ministry. How about the future? Yes, so far we do like that. How about the future? For the future, we established the digital health strategy 23 to 27. This is this strategy we already get approved on 2023. We start is implementing under of this strategy. You can see two main points, like a non-person central and the person central. How different is so far we don't use the person to be the central, like for the when you the delivery, you just individual registry in that hospital, or immunization. When this time you get the immunization in this hospital, another time when you go to another hospital, the data will different to be, even you go to hospital, 2 hospital, 3 hospital, your data will be different hospital. But it's right now we move to be the person to be the central, because just like one person have one ID. When you go to delivery or you get the EPI or for the nutrition, OPD, IPD also, you will have just one ID only. Even you go to another hospital, the ID, the information of the patient will be linked together. This is we try to move from the program, the centric, to the person centric. This is the strategy that we do. This one is for the DHIS2 tracker programs. Like I explained, like last slide, is so far we will see suppose the malaria. We will know only the amount of the person get infected the malaria in this week, just only the number. Is right now for we try to adapt to be the tracker program. We just know we just not know only amount, but we will know the person who get an infection for the malaria in that district or in that village. Another one also is HIV, TB also. It's right now we can know the person who get infected that diseases in that zone, in that area, or in that village. Compared to so far, we just know only among only. We don't know the person, but right now we know the person. This one, such as malaria, HIV, TB, start implement from 1918, and another one is 2019, 2023. But for this year, we developed like MCH, IPD, and NCD, and another one we will develop to be the tracker program, because it's very important, this one, because we will know specific know that person in that area, not only among like so far. This one we the DHIS2 for the patient health registry. For this one is we combine the information to the to one tool, as a DHIS2 because like EIR, delivery, NC, PNC, family planning, nutrition, we are put in the DHIS2. And another one, we still link with the EMR, link with CRVS, because CRVS is under of the Ministry Home Affairs. We still link with DHIS2 because we need to know is about the child birth, about the child death, mother death also. So even the under of other ministry, but we still link with our system is DHIS2. This one, we for the climate health, we still combine to or input to DHIS2 also because we in Laos we have developed a health national adaptation plan to monitor for the climate change because climate change is related with the health also. We still integrate the weather data into DHIS2 also for this one. The purpose we focus on three mains like dengue outbreak protection. So this one we very important because we can know in advance if we have this data. We in as well like we can know the trend dengue outbreak for this year or this time, something like this. It's a flood early warning. This one is very important also. Even the Laos country is landlocked, but still have flooding also. So it's early warning is very important also. Another one we have to research on integrate health and climate data to address the health issue. It's we link to the cause of heat wave or heat stress. For the heat wave or heat stress is very important also because the weather is very hot right now and get effective to the people a lot for this one. Yes, it's my presentation. Thank you very much for your attention.
Thank you so much, Director General Visit Kamlusa, for the presentation on the current implementation of DHIS2 in Laos and also the future plan. So I think we can take a few questions if you have any questions for Laos. I think. Yeah, because Laos just passed the 10 years anniversary of DHIS2 implementation, and most of the program now they are moving to tracker. So yeah, it will be a really exciting plan in the future. Yeah, I think we have one question for Rati.
Thank you for the opportunity. It was a comprehensive and interesting information for the implementation of the DHIS2 itself in Laos. I was interested when you were talking about the tracker implementation in Laos, and I was wondering what are the challenges that you face in terms of implementing the tracker programs in the DHIS2?
Yes. For this one, for the main challenge is about the human resource, about the person who respond the system, especially is the government resource person, because right now we still refer to the outsource. For this one, maybe as our colleagues, our team can support me to respond to the question.
Yeah, because I'm supporting Laos, so I can just add. So first is on the human resource, right? Because in Laos, we also have limited number of staff working, and the same person have to also provide treatment and also doing data entry. But instead of that, we also think that tracker will also help to reduce the data entry, because in the past people have to do aggregate, we have to consolidate, and then we also provide treatment. But then moving to tracker, we try to at least align this procedure and then to reduce the workload. Yeah. I think we can have one more, and then we can, if we have some time, then we can do in the, yes.
Yeah, I just wanted to, I can, for colleagues from Indonesia, I can say regarding the ER tracker, which is kind of a massive one, and this is not the case. This is surveillance, as you know. We need to capture every child. So one of the first challenge we faced was a unique ID code. So that was conceptually we had to discuss because there is a birth ID, and that is managed by the other Ministry of Home Affairs. So, and this is not full. I mean, so we have difficulty finding the right denominator when we start the process of ER. These techniques need to be discussed at the very beginning, at the conceptual phase. So if you would like to go for implementation of the ER tracker, later on you might also face an issue with the CRVS. So it is important to bring intersectoral groups for the discussion what you are going to do, and that using health facilities to register not only immunization, but also birth, children, live birth, would be beneficial. The other difficulty is, yes, it reduces paperwork, but at the beginning, first 2 years, forget it. You will have a lot of workload, and it will bring a lot of frustration. So you have to manage the frustration, because too many works, you know. So the second is, the faster you start using the data and then provide the feedback to which are entering data, and they can see benefit, then they will understand why they're entering data. Otherwise, just entering and data is going somewhere, there is no feedback, and it's going to be challenging. There are different parts. I mean, depends on who are your partners, whether you have World Bank, what they are doing. Duplication is a big risk also. Please be mindful. So start from the intersectorality, and then conceptual development would be the good start for any country. Thank you.
Okay, thank you so much, Dr. Sukrat, for your comments, and I hope that answered your questions. So I think we can continue the discussion during the break as well, because the participant will be here, and then feel free to the presenter will be around, and feel free to grab and have a more detailed discussion. So once again, thank you, Director General visit for the presentation. So next one, I would like to invite Ms. Tui from USCDC to share about the implementation in Vietnam.
Alo, được chưa? Hình như hơi bé. Ok. Good afternoon, everyone. I will share with all of you the Vietnam implementation using the DHIS2. Before going into detail of the CDC accomplishment and priority for the next few years, I would like to give you a quick overview Vietnam. Sorry. Vietnam surveillance system for communicable disease. The system had, as you know, in the Vietnam, the highest level we have the Ministry of Health. Under the Ministry of Health, we have the two agencies related with the surveillance system, General Department of Preventive Medicine and the Vietnam Administration of Medical Service. The system has mandatory reporting requirement at different administrator level, from the grassroots system to commune, district, and provincial and regional level. The overall lead up and coordinator for the surveillance system in the MOS is the we call General Department of Preventive Medicine. GDPM also oversees the national network of regional institute, and GDPM also support for the surveillance system, VAM overall the hospital system in Vietnam. And now we have the 4 regional institutes in the north, in the central highland, in the coast, and in the south. And we call the Pasteur Institute or the National Institute in Hygiene and Epidemiology. There are two agencies work very close in the together and provide policy and strategy guidance for the MOS, from MOS to related with the surveillance system in Vietnam. And in the public health, CDC also work and have the co-act with the 4 regional institute, and also have co-act with GDPM and VAM. That is overall the surveillance system in Vietnam, and with the activity related. Okay, sorry. In the project related with the DHIS2 in Vietnam, we have the several activity, and I already highlight the activity related with the US CDC. We support for the GDPM to develop, and right now we still waiting the decision to implement for the event-based surveillance system. We also support for VAM to develop the influenza monitoring system and support for GDPM and for regional institute to develop and implement it. Right now, we already implement in the GDPM and for regional institute epidemiologic data warehouse. With the event-based surveillance system, the system we use the tracker system and event system, sorry, and we already develop. Currently, we already developed the system to support for the health staff in the health facility when they receive the report and any signal and report on the system. This is the dashboard for the EBS system. Currently, we have the we input the dummy data because we still waiting the guidance to implement. Right now, the system already developed and complete by the DHIS Vietnam. For the entry data, we using the eye capture, and we also have the recognized winning site verification result and event report on the system. Screenshot display the form for people and entry data in the system, and of course the people can come back in the dashboard to see the overview or maybe see the accurate data. And this is the form for entering the new signal or event in the system. Because the time is only the 50 minutes, so I will pass to the next slide to introduce about another system we already support for, from the CDC. For the second system, we already support for flu monitoring system, and the system using the DHIS2 for the tracker. We also have the dashboard default for the influenza surveillance related with the laboratory data sector and the influenza surveillance for the hospital. Maybe have the several different, but I think we also have a lot of the benefit when using the DHIS2, and the people from the hospital and can see the overview and the data already visualized, or maybe have the making decision from the data in the flu system. For the data warehouse, CDC support for the GDPM and for regional institute, we already start from the 2016, and we already have the 2 phase to upgrade for the platform DHIS, and also upgrade the adding or expand the requirement from the end user to support for each regional institute. Again the Vietnam surveillance system to you can see we support for national institute, and each EOC we call the center, the emergency operating center, and each emergency operating center we have the data warehouse to support separate with them to manage data in Vietnam, we have the indicator-based surveillance. We call the electronic for communicable disease surveillance system, and using the another technology, but the software only support to enter data in the system, no function for the visualization and the analysis data. So we using the DHIS2 for the visualize data and analysis. Currently, we stand in the phase 4. We already passed from the 2016. Right now, we already stand here, and now currently we continue to support for the Ministry of Health to upgrade the indicator-based surveillance system. We call the ECDS, and integrate the EBS and IBS in the one system in the future. We also have planned to continue develop the regular and scope of work for on using the data warehouse, the indicator-based surveillance, and also the event-based surveillance to management and user. The data source that contribute to the data warehouse include routine surveillance system and the ad hoc data. With routine surveillance system, we have the main data from the ECDS. We integrate via the API by the daily. So the system, the surveillance, the data warehouse have the huge data. By the key report from the ECDS, integrate through the API in data warehouse in national and the regional level. We also have routine surveillance data from the technical team. For example, for each the regional entity, we have the general infectious disease. For the dengue team, HIV immunization team, they also have the data and they save in the multiple the program. For example, WHO program for the maybe from the Excel file, asset file, or something like that. Most of the data is accurate data. Or maybe like this, they keep from the lower level. So they entry data from the system, or maybe import the Excel file by the template we already developed in the DHIS2. With the Sentinel surveillance, we also develop and support for the data warehouse with the SARI and IOI, and for the Sentinel surveillance, and based on the requirement from the regional institute and the GDPM. We also have developed the event-based surveillance. Currently, we already developed, not under, and we also work with the laboratory system from the each regional institute, and already integrate the data from epidemiology and the laboratory system, integrate in one, and visualization data in the data warehouse. Besides the routine surveillance system data, we also have the ad hoc data from the outbreak investigation, and we have the general form to entry data in the system. Currently, we only enter data by the event, not have a checker in the data warehouse. And of course, for group ADZ, according by the 54 circular, for the infectious disease, we also had the form to entry data in the system by the K report. I went to demonstrate for the data warehouse we already implement in the Southern Region Institute. This is the system, the RAN system. We can see the default screen. We call the AP bulletin, because the people from the health sector using the information from the data warehouse to develop the report, routine report by weekly report. In the AP bulletin dashboard, we have the information for the own infectious disease. This information not requirement people entry data in the data warehouse. We have, I already mentioned, we have the another software we call the electronic for communicable disease, and the people entry the case report and patient report in there, and the API will the pull all data from the ECDS to the data warehouse using the DHIS2. For the each disease, we also have the dashboard to the analysis very detailed about the weekly or about the monthly, about the quarterly or daily. It's very detailed, and based on the situation, the people can analyze this and maybe can export data. I think that is the very useful when the people have the dashboard or maybe the data warehouse, because they can comparison a lot of the information. For example, relate with the dengue fever, we have the many information, and we put in the data warehouse, and we can comparison and give the decision or the making decision based on the data. In each regional entity, we also have the emergency operating center. It's not the only the room with the video conference and audio conference. We have the information, the data based on the server and data warehouse to display on the EOC center. For each regional and national, we also have the information that's the same. Some more info in the screenshot to show the distribution of case by age, by the sex, and we can see on the system the people customer can on off the age group, or maybe they can export data from the data warehouse. In the data warehouse, we also have the many functions for people, not only have the dashboard. We have the form for entry data. We have the form for people using the data in the and upload on the system. And currently, we also have support for every year. We have the training for the people in the regional entity. We have the core team and training. They using the DHIS2 and can custom the general form using the on the DHIS2 on the data warehouse, so that the people can each regional entity can manage the data warehouse from them. I think as the same many the country in Vietnam, we also have the some challenges related with the data interoperability, because from the hospital and from the public health center, we still have the separate or maybe the independent system. In the future, when in Vietnam we have the maybe the degree or the circular to requirement the data from the hospital, we maybe right now we call the EMR or EHR, and we establish the data center from the Ministry of Health. After that, we also using this data from the data lake and input in the data warehouse. That is a roadmap in Vietnam, and CDC also involved work as the technical assistant to support for the Ministry of Health to work very close with the Ministry of Health agency to develop and implement it. system performance because we only focus to develop the tool, and currently Vietnam still not pay attention for the security, for the server, and currently I think it's no problem. But when we roll out is a nationwide and the people using the EBS, I also want to learn from the Bangladesh or maybe from the Laos about the way you implement and is the EBS system when we have the help the people to using the indicator-based surveillance or event-based surveillance. The coordinate also is an issue in our system because we not only have the mechanism or maybe the regulation to request all the agency in the Ministry of Health to work together. So I think that is the overall information from the system and CDC support, and I will to finish my presentation, and hope to learn from you about the sharing or maybe a question from me on Vietnam situation and the CDC support. Thank you so much.
Yeah, thank you so much, Ms. Thuy, for the presentation on different implementation of DHIS2 in Vietnam and the usage of dashboard. So I think we can have one question if any from the audience. If you have any, can take one question. Okay. Okay, I think things should be very clear, but like I mentioned, we still have time during the break and the past 2 days for the more 2 days to discuss. So feel free to grab her and then discuss more.
Yes, thank you, sir.
Okay. Oh, you have a question? I cannot see. Sorry. Yeah. Maybe one question. Jung, can you pass the mic to? Yeah. Maybe you. One question.
Thank you for the presentation. So, Wanda from the Beach of Cambodia. Well, I'm curious about your event-based system. So, is it now the plan is to roll it out to all the district or only at the provincial level? Or, I mean, who register the events, and then who verifies, and who will like complete the process after that? And then another question is, you have also ILI and other surveillance system. So when other system pick up events, how the event can be linked to the EBS system? Or is there any linkage so far? Thank you.
Thank you for interesting question. Right now, I will answer for the second question. Currently, in the system, we still separate, not linked from the IOR and the EBS. It means from the EBS, event-based surveillance, we develop the tool, and we don't have any further next step to maybe when we have the signal, or maybe we already define this event, we don't have move this event into the indicator-based surveillance as the ECDS, because I think we have the different concept for the EBS. We mentioned about the symptom, or maybe about the outbreak definition. Maybe we can report for the event for 10 people, but when we enter data in the event indicator-based surveillance, we have validity by the patient record. Yes, very individual data. And the second, you mentioned about the level people using for what? For the event-based surveillance or the indicator-based surveillance? Event-based surveillance. In the event-based surveillance, we only have the decision. Not we. The Ministry of Health have the maybe I think not the decision. Okay, circular or decision, but the decision focus for the public health, not for the own health facility. So it means when when the hospital have the signal or something like that, the people, the health staff from the health center or the health district go to the hospital and recognize the signal, or maybe from the media or something like that. They keep data and they seen have the symptom and recognize the signal and report on the system, but only the people from the public health sector into data in the system. And sorry, because when I saw the screen in the Ministry of Health structure, you can see the workflow, the people report in the system for the event. But for the indicator-based surveillance, it means in Vietnam we call the ECDS. We requirement the hospital enter data in the system, but the people from the public health, from commune, from district health center will verify and confirm data in the system. Thank you.
Okay, thank you so much, Ms. Thuy, for the answers. So next, I would like to invite Mr. Kinli Doji from Ministry of Health Bhutan to present about the implementation in Bhutan.
Hello, good afternoon. Good afternoon. Okay, so I think we have seen a lot from the country presentations till now. I will also be presenting about the DHIS2 and Bhutan, how we have gone from just the data collection platform to the integration of DHIS2 as national HIS, and then the road to the annual household survey. The key concept of increasing the resilience of any health system to the new challenges is improving the national health information system. That I think everyone here will agree. And the management and the governance of health information and information system in Bhutan has been fragmented. And there are so many disjointed systems in the country. And when we look at these fragmented health information systems, if we look at all these national fragmented health information systems, then we can see a series of problems that comes with the fragmented health information systems. And one of the particular problem that we face in the developing countries is its reliance on the paper-based systems. And also the disjointed or the fragmented systems, the paper-based systems, and also not able to optimally use the digital interventions in the health information system. So in this presentation now, I will take you through the overview of the health information system in Bhutan. And we will also look at how we have implemented it and what are the challenges that we are currently facing. Okay. The rural government of Bhutan has recognized the potential of ICT and health information systems as and its positive impact in the healthcare. And in 2018, we have drafted this national e-health strategy, which is the roadmap for all digital interventions or the e-health technologies in the country, and in which DHIS2 has been recognized as one of the core platforms of national data warehouse. I must also say that Bhutan introduced DHIS2 in 2014, and since then, our journey has been kicking out the barriers, striving to achieve more, and also trying to break the general norm of we will not be able to do. So we are trying to break that and innovate new things in order to achieve our the goals. So since then, we have been trying to rope in all the stakeholders, and thanks to our continued support from HIPS India and also our WHO office. The WHO has been very generous in supporting all these implementations. So I think they deserve a round of applause for that. Oh, thank you so much. So they have been very generous and also working tremendously in these areas and trying to improve the health information system in Bhutan. Now, I think we have achieved a lot, and we still have many more things to achieve. So now, what are the jewels of successful implementation of HIS in Bhutan? If you look at, and if you also wonder why, what could be the small things that made it possible to achieve all these things in Bhutan. Bhutan is a very small country, by the way, but although it's small in size, if we iron all the wrinkles of Bhutan, the mountains, the slopes, we will have a continent. So that's how big is Bhutan. It's very small, but we have our own strategies to achieve it. With the rugged terrains and the geographical location of Bhutan, we have our own set of challenges, but we have our own jewels of success as well. So digital health strategy reforms are aimed towards improving the efficiency of HIS in Bhutan by refining the governance structure itself. And we have tried to restructure the governance structure of HIS in Bhutan by implementing something called the steering working group, who has been the epitome of the governance of health information system in the country. So we now take pride in having a very strong governance mechanism in place and the partnership of all our stakeholders. Because first thing that we need to do in order to implement any new technology or system in the country is buying in all our stakeholders, which is very important. Without this, we are not going to move any further. So we are proud that we have all the systems in place. And we also, the working group also looks at is also functioning as the critical leadership and providing the technical support both in changing the people and also the systems challenges that we face in the country. So we are also developing a very strong digital infrastructure in place in order to make all the systems in the country interoperable, and also integration of the current systems, the paper-based systems into digital ecosystem. Both the national health policy as well as the national e-health roadmap or the strategy master plan advocates in the use of digital technology in order to strengthen the health information system as well as the data ecosystem in the country. So now we have, although very small, in numbers, but we have a very multiple and robust information system in the country. We are also looking at the building of HR capacity, and we have completed the assessment of ICT educational needs in the country, and we are developing this training facilities in collaboration with the university in Bhutan. We are making all the courses online. So now, if you want to know about the digital health and also the health information system in Bhutan, so this gives you a very rough idea, but clear picture of how health information system in Bhutan looks like. So we have something called electronic patient information system, which we just implemented in 2020 and 2023. This electronic patient information system will capture the longitudinal patient information in the country. So it's implemented in all the health facilities, and now we are gearing towards its interoperability and also integration with the other systems. Electronic patient information system itself is a very huge system. It also pulls data from the CRVS system in the country. So we do not enter patient information like demographic profiles into electronic patient information system, but it's directly pulled from the CRVS system. And also DHIS2 stands as the core platform for us with so many data reportings in it. So now, let us look at the DHIS2 ecosystem in Bhutan. We have the tracker capture, where we have around 6 different tracker reportings in the DHIS2. We also stand as epitome of use of DHIS2 in the cancer screening programs. I must say that the use of DHIS2 in cancer screening, which we implemented in 2020 to 2023. We screened all the women aged 40 and above for cervical cancer. We also screened all women aged 30 and above for breast cancer. We screened all individuals in Bhutan above 18 years old for gastric cancer. We also tested for H. pylori. So during that, I must say that use of DHIS2 was abrupt, as well as the timely. Because I say it abrupt because we thought about implementing this at the 11th hour when we were about to roll out this screening program. But thanks to our HIPS team, who has worked tirelessly for implementing this, they have delivered this on time, and we were able to record this information in DHIS2. So we have the 7 modules in tracker capture, and we have 7 different aggregated reporting forms in the aggregated reporting in DHIS2. Now, we are also expecting to link it with the electronic patient information system so that DHIS2 and APs are linked together. Considering that data in itself is a combination of millions of stories, but if you don't disseminate it, the government will sit on piles of data lost without insightful or meaningful information. So we tried to disseminate this data through different platforms. Actually, we have used this in the DHIS2 has been cited as one of the major data sources for monitoring and evaluating the 13th 5-year plan of Bhutan, which is the overall plan for next 5 years, starting 2023. And also we publish the annual health bulletin, which comprises of all the aggregated data collected in DHIS2 as well as other information systems, also the paper-based system. And researchers have also tried to use the data from DHIS2. And one of this example is population-level cancer screening and cancer care in Bhutan, which was published in the Lancet Regional, which summarizes and reviews the cancer screening in Bhutan and how the cancer care is being delivered in Bhutan. So without evidence, I don't think many of us will agree, here will agree with me. So I have a set of evidence how DHIS2 has been successful and how it is shaping the health information system in Bhutan. So from the Chief of Policy and Planning Division, who actually does all the planning in the health, says that it not just created a sense of responsibility and accountability, but it has also made data available for policy decision making. And from the head of HMIS, he says that availability of the data at central level, and it has helped in monitoring and evaluation of the data, the plans and programs. Now, from the district health offices, so we cannot just look at the national level, we had to go down to the district level as well as the health facility level. So district health offices says that it not just saved their time, but also improved the quality of data. So this is how DHIS2 is shaping the health information. From one of the program managers, he says it's easily customizable and also helps in disease surveillance. This is from the malaria program in Bhutan. And also from the health worker, says it's just not, it's very convenient, as well as it can record the information offline as well, which is one of the key features of DHIS2. Okay, so in many of the settings and in our previous presentations also, we have questioned our quality of the data, admin data. And we are also concerned, equally concerned about the quality of admin data. So we wanted to see whether, how accurate could our DHIS, the data recorded in DHIS2 be? So in 2023, we conducted this national health survey. By the way, as information to the gathering here, Bhutan conducted this national health survey. First time in the history, we consolidated 14 surveys together, including the DHS and also the STEPS, NCD STEPS survey together. So we have 14 surveys being consolidated, and it turned out really well. Now we are comparing the National Health Survey data with the DHIS2, the admin records. And as you can see on the slide, how accurate our admin data is. NHS 2023 says neonatal mortality is around 6.9, but from DHIS2 it's 7. There is statistically insignificant differences in the figures. Also, if you look at other key indicators also, it shows the similar trend. So I'm thinking and hopeful that all our other indicators will be same as well. We have a mouthful of success stories, but we also have a handful of challenges that we are facing. As a small country, resource-constrained country, we always have these financial challenges, as well as the lack of appropriate communication infrastructure in the country. So with all these rugged terrains and geographical location, we have the low internet coverages in some of the far-flung areas, which poses us so many challenges, and also the human resource competency. So human beings are one of the most difficult species to deal with. Number one, we lack knowledge of how to use this system. Even if we have the knowledge, because of our the pre-defined concepts in our mind, we are not ready to change and adapt to the new systems. So these are the major challenges that we have. And also on the clinical service delivery and data management, the public health and clinical. So we have all these challenges in. And then also stakeholder collaboration. As we all know, all the stakeholders has their own mandate. And if my mandate doesn't align with their mandate, they are nowhere to be seen. So that is the major challenge. And I must say that in any in implementation of anything new, we must first bring in the stakeholders. Without this, I don't think we will be successful at all. I've talked about how it's functioning in Bhutan. Now let me take you all through our future plans in DHIS2. So DHIS2 will remain as one of the core platforms for the National Data Warehouse to facilitate health data, and then also for linking multiple data sources. It will also be the base platform to support different program areas and also develop new systems, information collection platform. We are also thinking of connecting electronic patient information system with DHIS2 as well in the future. So this is the major task that we have undertaken now. We hope that we will be able to deliver it successfully with support from our HIPS partners here. We had this household surveillance, which is paper-based. But when we say household surveillance, many think household survey, many of us might think that it's kind of a survey that we conduct annually. It's actually household surveillance where they go for public health activities annually. And this covers each and every household in Bhutan. It's just around 120,000 households. So we are covering all of these households. And initially started as household surveillance. We have combined this annual household survey. So we have this public health interventions as well as the information collection questionnaires, which we deliver it through the annual household survey. So now our effort to digitizing it. In 2018 to 19, we tried this using these different platforms like EpiCollect or Excel or Google Forms, which did not fulfill our vision. So now we are trying to build this in DHIS2, and we call it the Integrated Public Health Surveillance and Primary Health Care, because we are also trying to integrate other public health surveillance and screening into DHIS2 through this model. So I hope we will be successful. Now, finally, I would like to end with the quote from His Majesty, the King of Bhutan, where he says, digital infrastructure and digital connectivity is equally important in this age of artificial intelligence. But what deeply concerns me is whether our people will be able to take advantage of these opportunities, or if we will be left behind due to our inability to adapt. So I think this quote not just reflects the condition of Bhutan, but equally reflects all the conditions in all the developing countries and similar countries like ours. So I hope we will not be left behind. Let's work collectively. That's why we are here together. Thank you so much. And if you ever plan to visit Bhutan, don't forget this place. Because it's not just irrespective of your religion, because this is not just a Buddhist center, but climbing uphill will make your heart beat faster. It will also make your muscles move stronger. You will live healthier, and we will have similar gatherings in near future, many more to come. Thank you so much.
Okay, thank you so much, Mr. Kili Dochi. So I think we can have one question if anyone would like to ask the Bhutan. Maybe just one, maybe Hanan.
No questions that I will not be able to answer.
No, that will not. You were telling us about the cervical cancer screening. So we are in Bangladesh, we are also doing the cervical cancer screening and also the breast cancer screening. But are you only screening, and then what happened? What about the outcome, the result? So are you following up for them, or whole treatment cycle is there or not? In Bangladesh, we have near about 3 million already screened. Total about 5 million are already enrolled, but they are treat and follow up. So whole cycle is there. So what actually your plan and what you are doing actually?
So I think it's similar in our context also. We start from the screening and then goes till the treatment and then also follow-up visits.
Okay, thank you. Thank you so much, Mr. Kinley. And yeah, oh, one more. Okay. Can
Okay, thank you so much for the presentation. It's very interesting. I have some questions regarding the challenges. I find it's very interesting about the clinical aspect versus the data management and neuro attitude. Can you explain a little bit more on that, like a concrete example for me, so that which is, to me, I find it's maybe some similarities in Laos as well for this one. And the second point is about the stakeholder collaboration. Is that the private hospitals you mean? Can you explain more on that one? Yep, thank you.
Thank you so much for the questions. Now, number one, it's about the clinical versus the data management. So in Bhutan, in most of the health facilities, we do not have data managers. It's the health worker who will be doing the reporting. So there's always a push and pull between the clinical services, the delivery of the services, because the health worker's main mandate is to deliver the clinical services. But they will also have to do the reporting, data reporting. And in many of the cases, when we have so many parallel reporting systems, the health worker lands up doing more of data reporting than the clinical works. So this is the one of the major challenge that we are facing. And it's because we have so many human resource constraint in the country, and also contributed by the ever-increasing attrition rate. So we have a very limited pool of health workers in the country who is doing so many works, including administrative work of the hospital. So this is one of the challenges. Other thing, I think you mentioned about the attitude of the people. So it's not just the health workers, it's even the program managers as well as the general public. For all of us, if we want to implement a digital solution in the country, first and foremost thing we do is reject. We always reject something that is new because we do not know how it will work out. And then in a process of saving our own head, we'll end up losing a huge chunk of data. So this has always been a process in our developing countries. Because every time we introduce a new thing, it's always one step in and one step out. So we don't want to really jump into it, and then, because we do not see the future. We are not clairvoyant, so we do not see the future. So we are all bounded by all these misnorms as well as the preconceived ideas of not, it will not function. So that's number two. Sorry, the number three you said was stakeholder thing. So stakeholder, in Bhutan, we do not have any private hospitals. And the private diagnostic centers are also controlled. We do not have many the private diagnostic centers. We have only just 4 to 5 private diagnostic centers. And with the population like in Bhutan, and also the constitution of Bhutan states we have to deliver free health services, healthcare services to the citizens, including education. So there is no private hospitals. But what I mean by the different stakeholders is, firstly, within the ministry itself, we have different programs. And each program will have their own set of reporting forms as well as their own system. So that's the internal stakeholders. Now we also have the external stakeholders like National Statistical Bureau. We also have the research organizations. We have the university, and we also have the CRVS, the Ministry of Home, who controls it. So without bringing in all this, and also the GovTech agency who looks after the digital infrastructure in the country. So without all of them coming in, and without having it as a whole of a government, whole of a society approach, I don't think we will be able to move any step further. So that's what I meant by the stakeholder consultation. I hope I clarified your doubts.
Okay, thank you so much. I think we have a lot to discuss, so I would encourage we can take that during the break, so you know the presenter, so feel free to grab them. Next, we still have one last presentation from Indonesia. Maybe I can invite the representative from Indonesia, and then because we started 10 minutes late, so we can take that from the break. So we have one presentation. So may I invite Rati from Asia to come? Can we have the on the screen?
The third annual DHIS2 Asia Pacific Conference, hosted by the HISP Asia Hub. This year, we're joined by 75 participants from 10 ministries of health, 11 partner organizations, members from DHIS2 core team at the HIS Center, and my colleagues from 7 HIS groups in the Asia Pacific region. Through the conference days, we aim to exchange ideas, share innovations, and strengthen our collective efforts.
Okay. Good afternoon, everyone. My name is Rati, for short. Yeah, Rati Shabrina from HIPS Indonesia. I'm not here alone, but I'm with the Ministry of Health, a representative, Mr. Damish from Indonesia as well. So today, we would like to share our experience in implementing the DHIS2 and work collaborate with the Ministry of Health. For the introductions, I would like to share with you about our geographic information in Indonesia. We are an archipelago country, over 17,000 islands, with 38 provinces, 514 districts, more than 10,000 primary healthcare, and more than 3,000 hospitals in the country. And so Indonesia has a vast and complex health management systems, indeed. On top of that, the Ministry of Health has started to adopt this platform, the DHIS2, since 2016. And moving fast forward, 2018, they have expanded the DHIS2 utilization for its One Data initiatives, and also called as ASDK, or its abbreviation for Aplikasi Satu Data Kesehatan. And it is also being supported by the published of this presidential regulation or decree for the health systems, which the initiatives is One Health Data. And the ASDK, or Aplikasi Satu Data Kesehatan, was officially launched by the Minister of Health. And this is the event took place in 2019, where the data availability in the platform includes so many programs. We took it for the disease data, health facilities data, health human resources data, and health financing as well. So where is the data coming from? The data sources for this ASDK is actually coming from a point. The first is some of the health facilities still carry on manual data entry. So they are still Excel-based or paper-based. And then they also have like EMR. And they also have platforms like individual data and aggregate data from other platforms. And for your information, the Minister of Health has invented, they have like doing an assessment, and it is over 400 health applications distributed across the nations. So this is one of our big challenge to tackle the health management system. And as you can see that this is the middleware. So from all of the data entry, even if it's a manual or is it by system, they will go straightforward to a middleware where the Ministry of Health has taken the initiatives to use the standardized middleware using the FHIR standard. And it will going directly to the ASDK. And the data will then going for disseminate like through dashboards and for data analytics matter. So there are lots of programs that being implementing this DHIS2 platform, but I will highlight one of the most recent implementation in the surveillance, which is the rabies program. So in 2020, Indonesia has launched the roadmap for rabies elimination by 2030, echoing the global commitment zero by 30. So one of the provinces in Indonesia, which is Bali, maybe you've heard of Bali, right? Yeah, Bali has become one of the top 10 heavily infected provinces for rabies, and the reported incidence of rabies among human reach more than 51 to 150 cases over a million population. So in 2023, 6 rabies deaths, 62,672 of rabies transmitting animal bites were reported in Bali itself. So on top of that, the District Health Office of Denpasar City, Bali, launched an application using the DHIS2. They call this as DIREC. Yeah, so this DIREC is to strengthen the surveillance of rabies in addition to other information systems such as the EMR and SMILE. So this SMILE is actually another application for immunization logistics, and a web-based application to digitize the vaccine supply chain system. So how can this DHIS2 being implemented? Because it's not only like a system and not only users, but we are going to focus more on the data use. So monthly routine data use meetings in Indonesia's primary healthcare is being conducted routinely, monthly and quarterly, which we call is Loka Karya Mini or Lokmin, like a mini workshop. So all of the primary healthcare and the district health office gather together, not only for the health sectors, but across the sectors as well. And then they have the meetings to establish effective teamwork across these programs and sectors, as well as to monitor the primary healthcare activities, results in accordance with the planning, and then to identify the problems and obstacles in the implementations of the PHE activities, and then to identify the causes of problems and efforts to find the solutions. And on top of that, they will formulate a work plan for their next period. So this is one of the documentations. Meanwhile, the Lokmin is conducted. And as you can see, these are the rabies registry format in the primary health care. And below is the health book for the monitoring for the rabies transmitting animal bites cases. This is coming from one of the primary health care, or we called it as Puskesmas in Denpasar. So the monthly PHC performance report for rabies is being discussed routinely, and they use direct dashboards for the tools to then formulate the work plan and to allocate the resources needed for the areas that needs for the rabies transmission. For example, this is the one of the data. Like they have found out an increased number of rabies transmitting animal bite cases, and the meeting was being led by the head of the Department of Data in the district health office. So when we talk about the challenges on the implementations of the DHIS2, especially in Denpasar, the current condition is for the rabies itself, the individual report is still in Excel base and or paper based form. And the second is multiple recording reporting. So they have to manually aggregate the individual data for several reports. And DHIS2 deployed Direct, which is currently use the aggregate data. And they have faced a challenge where the delay reporting from the first case identification to the routine reports and no specific variables for location where the patients are bitten. So the intervention, when we're having this routine meeting, we have formulated one of the several steps to intervene this condition. The first is the additional variable for location where the patients are bitten. And then the second is dashboard with geographical distribution of the cases until the village level. So the PHC will then know where is the patients are bitten and where is the village locations. And for the potential solution, we have the individual data form in Direct, which is the DHIS2 based. And then we propose the alert function in Direct based on the definition of the rabies outbreak. And then the feature where to input the data can be downloaded for routine data use meeting in PHC and integration between the EMR to Direct for standardization of reporting template. So this is one of the dashboard that is being able to see in the Direct platform. This is the geographical distribution of rabies transmitting animal bites in 2024. So there are still a lot of cases that we need to combat from the DHO. And for the potential impact from the previous mention of potential solution, the first is because of we propose the individual data form in Direct and the download data feature in Direct, integration between the EMR, the alert function for disease outbreak, and the dashboard with geographical distribution of the cases. So the potential impact will be like to reduce the burden and time of reporting the rabies cases in several reports for rabies, and then faster reporting, faster response from PHC, DHO, and cross-sector, and then more complete individual data for case detection, more accurate, and then alert for disease outbreak can be more faster, and can be the source of data for anti-rabies vaccination procurement. And for the potential solution in define routine data quality assessment and create an SOP for rabies routine reporting, the impact will be to increase data quality of rabies cases. Well, that's one of the use case that we use for DHIS2. Actually, there are still more on the implementation of DHIS2. We have digital maturity index, where we actually assess the readiness of the maturity up to hospital levels. So we identify yearly data. And then we have the Public Health Emergency Operations Center, and then Jakarta Data Warehouse, Maros One Data, Sehatami, and Malang Simkas. All of these are various platforms that is being used at the national and at the subnational level because they have the authority to develop their own system because it is decentralized. That's why each of the province have initiative to use this DHIS2 platform, and they began to expand the use not only on health sector, but to education as well. Yeah, so these are the documentations that we had, working closely with the provincial health office and engaging the primary healthcare, and then they use the DHIS2 for monitoring their routine data. And thank you for your attention.
Thank you so much, Rati, for comprehensive implementation of One Health in Indonesia. So maybe we can have one question.
Thank you for the great presentation. I just had one question in terms of the quality of data. That what measure has been taken to improve the data quality, and how effective that was, and what was the challenges during the implementation of the data quality? Thank you.
Thank you. That's very interesting questions. So in terms of data quality, we have referring to the WHO guidelines in terms of completeness, and then consistency between indicators, between periods, as well as outliers. So these 4 parameters that we are encourage the district health office as well as the primary healthcare to see when they are inputting their data until they giving the feedback back to the primary healthcare. And the challenges that we face is currently on the implementation of every programs is the completeness rate. Completeness and outliers. It seems that because we have multiple and fragmented systems, it seems that when we aggregate it to the national level, we have so many missing data coming from the PHC because the human resource constraint as well. And we can't deny that this challenge also being filled by the other countries as well, but Indonesia has its own also a challenge for the human resource as well. So that's maybe one of the, I hope that clarify your questions. Any more questions? Yeah, sure.
Thank you very much for nice presentation. Just a question about the surveillance, and as you depicted in the presentation, we see the interoperability, the integration, let me say, the ecosystem. So do you have like a thought on how to integrate the disease, the IDSR I mean, or EWARN, because you have some issues like rabies. So any thinking about how to integrate it within other disease reporting system? Thank you.
Thank you for your questions. So we are not there yet to integrate all the surveillance data. However, the Ministry of Health started initiatives taking initiative of Satu Sehat platform, which means the one data. So it's a different platform use. It's not DHIS2 based, but it using the they build their own framework with the FHIR standardized data, and this Satu Sehat platform eventually send and integrate data with EWARS. So the local EWARS system is being communicated with the Satu Sehat platform. But in practical, they're still progressing because we're still on standardizing each of the variables and metadata for EWARS and both for Satu Sehat. So yeah, we're still in process. Yeah, thank you. I have one more question over there. Yeah, please. In practical, they're still progressing because we're still on standardizing each of the variables and metadata for EWARS and both for Satu Sehat. So yeah, we're still in process. Yeah, thank you.
Thank you very much for a very good presentation. I'm Dr. Inam from Pakistan. I'm sorry, maybe I have missed that, but you did not mention anything regarding the private sector probably. So how you are managing data of the private sector? Because in one of the previous presentations, they said we have no private practice. Like in Pakistan, we have a huge private sector. So what about your private sector? And I mean the data, and how you managing that? Thank you very much.
Thank you. So for private sectors, for instance, like hospitals, more than 3,000 hospitals, half of that is coming from a private sector. And we're still challenge ourselves in integrating all of the data from the private because they still don't want to share their data to the Ministry of Health. And as of now, the Ministry of Health actually published a decree to integrate all of the EMR system to its Satu Sehat platform, and in which the impact is if the private sectors, or even not all of the private, including the government sectors, they don't want to send their data to the Satu Sehat platform, it will eventually impact it to the accreditation. So that is like a force coming from our mandate from the Minister of Health to the private sector. So as of now, when you see like there's actually a dashboard, Satu Sehat platform dashboard, and you can see all of the information regarding how many health facilities are connected to Satu Sehat, including the private sectors. There are numbers there. So in managing that problem, the Ministry of Health published a decree, and eventually they send the data. Even it's not like 100%, but we're trying. Yeah. Thank you. There are numbers there. So in managing that problem, the Ministry of Health.
Sorry, one more question.
I can have a quick one. And then
you mentioned that there has been monthly data meetings among the primary healthcare, right, and the district office, something. Was it conducted nationwide? You mentioned that. Yeah, that's the question.
Okay. Yes, it is conducted nationwide. Yeah, because the Minister of Health also have the, like a level of, we can call it lockmin, right? The lockmin at the national level, and they cascading down. So there's a cut-off date for among the PHC to do this lockmin with the DHO, and then it's going to be validated at the provincial level and eventually at the national level. So it's like a routine data. For PHC, it is conducted monthly. However, for the national, it's conducted in quarterly basis.
In person?
Yeah. A representative from each of the PHC are coming to the district health office. And that's what, yeah.
Wow, thank you.
Yeah. Thank you.
Okay, thank you very much, and I think we can continue with the Q&A during the break. Okay, so would like to thank Ratri for great presentation, and would like a round of applause for all the presenters. So I think that's all for this session. But before we go into the break, I would like to have two announcements to make. So the management team just informed me that we can have a full break, so we can start the next session at 3:45. That's okay, so we can have a 15-minute back. And also for the next session, as you know, we will have two parallel sessions. So for the first one will be on the ICD 11 and mobility, and another one will be on education and health. But in terms of the arrangement, it will be in this same room, but they will divide the room into two rooms. So for parallel session 1 will be in the middle section. So that will be the room for the session 1, and the at the end will be another room for education and health. So when you come back and then you come back and then you use the door, that will be the room 1 and room 2. So depends on the session you would like to attend. If you have many people, you can divide to join. Yeah. I hope that's clear. At the end will be another room for education and health. So when you come back and then you come back and then you use the door, that will be the room 1 and room 2. So depends on the session you would like to attend. If you have many people, you can divide to join. I hope that's clear. Okay, guys, so EMIS will be at the end. So for ICD 11 will be these two room, big room. Okay, for the screen, these two screens, you can see.
So we will divide this room into two. The partition will go there. So CASA 1 and CASA 2, this gate is for ICD 11, and CASA 3, that gate will be for education, right? Yes, the door there is for CASA 3, CASA 1, 2 is for ICD, okay? Room into two, the partition will go there. So CASA 1 and CASA 2, this gate is for ICD 11 and CASA 3. That rate will be for education.
But like even in Laos, you had a monthly routine meeting with government. It was, but now it's closed. Now no more. No more monthly
No budget. Especially in person.
Okay? Just wait. Okay? It's fine. You can close that door. You can close that door so that if they don't listen, they will listen to the other side. It's fine. You can close that door. You can close that door so that if they don't listen, they will listen to the other side. It's okay. Okay, we start. Okay. So I know like you've been having the long day. Okay, we start. Is it mine or? No, it's the. Hello? Hello, is it okay? Okay, perfect. So the whole day you've been listening in, like lots of presentation, country presentation and all. So we want to change few things this time. We want everyone to participate and just say like all things are. So what I'll try to do, this session is about ICD 11 to use for both for mortality and for morbidity. So these are the two things which we will go through. There is an online demo. We will all try to access that one and we try to just see if it meets our needs and what are all the different things which are already there in the app itself. This app, what we call version 2, the first version which was implemented for quite some time, I'll give you the background and all. And then after the ICD 11 cause of death, we go towards IPD, morbidity data, and how that links to the cause of death. And then I want country examples. This app, what we call version 2, the first version which was implemented for quite some time, I'll give you the background and all. And then after the I just been told we have many people around here. Like if you have any problem in logging in or anything, so then you can always ask. Okay, so the people are here, just raise your hand and then they can help you around if there is any problem in the login or any kind of things, okay? But first, don't log in. Okay, for 2-3 minutes, just like have a look. What is there, what is the background and where we go. I will do a quick demo and then like we can try to focus on cause of death itself. Is that fine? Yeah, I want to try to finish as quick as possible because we know we have a gala dinner. But first, don't log in. Okay. So the first section is cause of death. So the background was like, we know like we've been using DHIS2 for many programs. And then like they want to try to use the cause of death module and linking with ICD 11 inside DHIS2. So there have been many efforts been happening around. This was, I'm talking about in the time of 2019, 2015, 2016, not now, okay? That particular timeline. So that particular time, people were just like configuring inside DHIS2, either making it as a different app or configuring the custom form itself. And there were lots of effort for developers and everyone, and also for the program manager to implement cause of death module in DHIS2 itself. Yeah, so given that one, so what was the need is like we wanted the cause of death, because like we know like we want to get accurate data on death including the cause, so that like we can try to do the analysis, do all the trends, and also share the data with the ECRVS system so that like, they can give the death registration, so the medical people can actually give medical cause of death to the people, and they can take that certificate to other places. And then also do the standardization in the process, so that like every hospital in our country reports on the same death. Because sometimes we'll just like say, okay, heart attack in one place, cardiac attack in another place. So those were all the different non-standardization which was happening. So then they tried to use the ICD to include the cause of death. So we had ICD-9, ICD-10, and ICD-11. So this one, ICD-11, is an online coding tool which actually has list of all the diseases and everything. And whenever they update, so it's just there in the online. So we can try to use it as and when it changed. For example, like we also had a problem in Laos, where we have ICD-10 now because of the translation. And the ICD-10 version is very different from the global 10 version and from the other country 10 version. So these were all the problems which were happening in ICD itself because of the different version release. Now with ICD-11, most of the things happens in the same thing. So every country is linking up with the same repository, so that like, we can try to get standardized way. And also it been translated into many different languages. And then we want to try to include that one into DHIS2 itself. So what happened in 2021? WHO Data Analysis Department, another division of Data Analysis and Delivery Impact, DDI, contracted DHIS Vietnam to try to build a generic module so that like it can be in the app hub of DHIS2. Like I mentioned in the previous time in the morning about the extensibility, so that like we can make this app where most of the DHIS2 people can actually install in their DHIS2 instance itself. So this one, like we started building, we got all the different requirements, and we just say what are also other needs what you want to try to do. We always say data entry is one part, it's not the end part. So we also want to try to include the analysis. Like for example, top causes of death by chapter, cause of death by different diseases. So all those things we want to try to include in the app itself, so that like end user don't have to create all the dashboards and everything again and again and in different places. So it's also very useful for us to give the training program, to conduct the things, and also focus on the data analysis part. So these were few of the comments. The other one was on the Anaccord export, because like when we have the ICD-10 causes of death, we want to, most of the people were exporting into Excel so that they can try to use it in Anaccord. So we also had a functions on that one. There are also some places where they wanted to automatically link the MCCOD to ECRVS, which is also electronic. So we wanted, instead of people doing the double entry, we wanted to also transfer the data over there. Since DHIS2 allows the FHIR integration and other things, like it has a strong integration mechanism, so it was feasible to do the data collection inside DHIS2 itself. And there were a couple of machineries which we were thinking through, how best we can try to achieve this one, and what should be the design inside DHIS2. Whether we create it as an aggregate, no, right? Because we have to have the names of the people, so we cannot do it in aggregate. Yeah, can we do it as an event? Yes, you can do it as an event, because like person dies only one time, at least here. Maybe in the movies we can die, like especially Indian movies, a person can die 3 times and can come back again and die again. So, but like they say, why are you not doing it as an event? I just say like when you do it as an event, especially linking up with the ECRVS and other places, it won't be feasible because of attribute. And we want to encrypt the person name and all things, so that like when we do the data transfer and all kind of things, we are doing it in a more secure way. So those were the design principle what we used before putting anything into DHIS2. Then we tried to make the module itself. And then what we said, like it has to be easily configurable. So like when I give the cause of death app to any country, they can just like open, and as usual we always just say test it in the development instance, not in the production instance. So they can just download, open in the app hub, click on the app, install it, and there is an installation step where they can select what all different things, people are trying to do. I can go through a quick things on during the demo. And then it has to capture data. That's the main thing, including the ICD-11 with the interface for all the different things. Very simple data entry, so the end user don't really have to worry about the DHIS2 workflow. They can just worry about the cause of death workflow. So cause of death workflow, what we have is when it was reported and when it was death. That's it. And then like enter the patient details and then do all the medical diagnosis data and all the things in the cause of death app itself. Yeah, and then that particular time we were just saying everything is online. Why don't we have this automatic underlining cause of death? Before in ICD-10 and ICD-9, we have to select underlining cause of death manually. And then the DHIS came up. DHIS, not the person, DHIS the tool. So in that tool, like what happens, it creates automatically underlining cause of death, and it will give you the reason also why it has selected that particular underlying cause of death, which people can review it and just say, yes, it's fine. Or we also have other options that we can try to do that one up. The other one is customizable cause of death. Because most of the, customizable cause of death certificate. Because different country has a different ways of doing the cause of death. They have a logo, they have like just say first name, last name in some places. They have signature of the hospital in the below. Sometimes it's in the left, sometimes in the right. So all those things should be easily configurable. When I just say configurable, not by the developers, by the health program people who knows a bit of IT itself. So those were the different things which we are targeting at. If a non-programmer, a non-developer can customize all these things into their own DHIS2, then we have achieved that particular level. Another part was on the data analysis part, which we can try to have custom dashboard, which we think, or WHO HQ think this is a good dashboard layout and good chart, so that the people can try to easily visualize the data, what they have entered. And one other key issue was on the translation. Because like we know, like we don't speak one language, and like I guess like tomorrow in the evening, like Jon will give you a few of the examples about the language problem in Southeast Asia. Like every different country speak different language and different script, so no one can read. So we need to have a very good internationalization tool built in right from the design part. Not only the data element, which has been translated in DHIS2, but also the UI. Like for example, certificate or save, delete or complete, all those things should have been translated into local language. So those were also some of the things which we try to include up, and also give an option for the administrator who can change the language if it does not make any sense. So there is an interface where they can actually change the text or the key text for their needs. Even though like it has been translated in one language, for example, let's just say Spanish or Portuguese, for example, Brazilian Portuguese and Mozambican Portuguese are a bit different when they talk about the same thing. Similar kind of way we can try to do it for different languages. Same thing in Vietnamese. At least like written is fine, I guess, but like still. And these are the few snippet. I just want to show this one because like then you are going to try. So these are automatic one where you can try to select particular dashboards and all kind of things. You can try to get all these things on the screen itself. So first thing was broad causes of death. So what are all the top 10 causes of death? Then it was causes by age and sex, non-communicable diseases, and then TB, AIDS, and malaria, causes by chapter, causes by ICD-11 cause group. All those things were included in here. And then like people can again select. All this analysis is based only on yearly. We didn't want it to like overburden the things, like to make it monthly, especially on the mortality, right? We just said yearly, and then people can select different kind of organized province or district or other places to do all the things. So, yeah, these are the other dashboard. Just an example. We don't have to go through all these things. Just like saying these are there, so when we log in, we can try to just see what are all the things, whether it's working or not working. Okay? And all this data, what we are looking at is dummy data. Okay? And then we also have Anaconda export. So where you can select actually a particular year and you can export all the data which is there in DHIS2 to a CSV or a Excel format, which can be included into your Anaconda export file for doing further analysis. Okay. This is the administration unit where the people who has permission to change. This was the things I was talking about, the medical certificate of cause of death, where you can upload your own logo, where it has to be. You have a header, the body, and the footer, where you can actually just say what kind of data should be where. And it's also possible to do something like this one. You upload just the PDF file, and there are some places where you can try to just say name has to go in this particular area and all kind of thing. That's also is a possible way of trying to deal with this. To just produce the certificate so that we can try to give. The same kind of technology was also adopted, which Sam was explaining, that when they do the birth certificate, it's the same technology behind this one also. So we started with designing the form like this, and we use it for also for the birth notification. Okay. So that's all the basic background. So now let's actually just see how we can try to log in and all. For doing this one, we need laptop. We cannot work with the paper or the book. And please connect to the internet, DAP 2004. And then, okay, let me just change this. How we can try to log in and all. For doing this one, we need laptop. We cannot work with the paper. So if you just go for dhis2.org/WHOCOD. And then, okay, in your laptop, sorry? Oh, .world. So if you just go for dhis2.world/WHOCOD. So if you enter, the username password is just there. Don't enter the username password yet. Let me explain what these things are. So there are two parts of user. One is a user who want to do both IPD and cause of death together. And one part of the user who just want to do the IPD, who don't have access to COD. We can also have one more user who have just access to COD, but not about IPD. Okay, so these are all the configuration you can try to do. What I suggest, use the first one so that we can actually review both the system, how it works. So use COD demo, COD_demo, and then the password is demo with D as capital @1234. Please don't use this kind of username password in your production instance. This is a very good example for bad password. Okay, so let me also try to do that. The password is demo with D as capital @1234. Please don't use this kind of username password in your production instance. This is a very good example for bad password. When you go, these are all the things what you just see. So DHIS2 dashboard, where we have included few of the resources there. The functionality, the download of the app itself. I'll tell you not to download the app yet, I'll come to that one a bit later. And then, so go for the app and click on ICD-11 causes of death. Okay, are you with me here? Okay. So when you click, it will take some time. Are you with me here? Okay. So when you click, and then we'll have the organizational unit. Let's just all select animal region, cat district, and cheetah. Let's just all select animal region. Okay. The reason why I'm selecting this particular facility is just because there is nothing there. So we can try to create. So then I know how many people are creating how many data, okay? So now we are trying to do a new registration of one particular person and do the MCCOD, okay? There are few hidden features. First, click on registration. Reporting date, let's just say today. And he died on Sunday. Let's give a name. Lily and Lily Fox. You can select the age. Let's say 60. No. Let me just take. Yeah. So when you select date of birth, it will show you the years. You just select female. It's up to you. And then you can give the current address. The few things which you have to just see here, this is the cause of death system ID. This is something which is generated by the system itself. It doesn't mean that like when you adopt in your own place, you can select what are the different attributes you want to use. Okay? So let's just say Danang. And I just say. So now what we have done is with respect to the tracker part is we have created one particular person. So now this part is here. So one good thing, like now I've done the registration, I don't want to do any kind of things. I can just like collapse it, so then I have a bigger screen. Okay. So here, this is where now, how many people are here from our medical doctor? So here, this is where. Okay, 1, 2, 3. How many people are here from Jason? No. Okay. Me too, I'm not that kind of doctor. And like we have Nick here, who is also very good in ICD, and Saurabh too. So I just got to know how to enter only one kind of things. So I'm just like doing that one. So in ICD 11 part, we have two sections. Before we didn't have this one. We had only the ICD, this part. We didn't have the free text part. So the free text was like what people are entering they wanted to collect and what also like they're selecting in the ICD. So like for example here, I just say attack. Okay, I click on coding tool. Now we are all inside DHIS2 itself. We are not traveled anywhere. So when I click on ICD coding tool, now I'm not inside DHIS2. I just say same. Now I'm not inside DHIS2. And then I get here. I select this one and say okay. And let's just say time heart attack was 4 hours back. Okay, and then let's just say okay. So I'm just like try to type the same thing. So now like here, this is the searching tool. Like when you click around here, you can actually just see all the different details, what it means. And this one is from ICD coding tool itself. And then this has been translated into Arabic, French, many other languages. So when you change the DHIS settings to your own language, you will also see all these things has been changed to your own language, okay? Okay, let's just say this one was 2 years back. Then I just say things. Okay, I just select this one. Okay. And then like it was 4 years. So So these are all the different things what we have selected now. And then like the people have to click on what is the underlying causes of death. Whether it was heart attack, kidney disease or diabetes. We all know what it is, but like I don't know. So I'll click on process. Before doing that one, what I'll try to do is I'll expand this. And this is the output from the DHIS, so that we can try to compare. There are also the other parts which I need to fill in. Just for the time limit, I'm not filling in. Because DHIS also takes all this data. Manner of death, maternal death, and all different kind of things. It also takes that one. Just for the simplicity's sake, I'm just like doing only this, okay? And then I'll click on process. So now if you just see, if you cannot see here, the DHIS has selected a checkbox. And then in the left-hand side, you have all the description why it has selected this particular, which is diabetics, as underlying causes of death, based on how things are, okay? So this is the simplest one to try to do. You select all these different things. You can also do the surgery. You can have the manner of death. If it is women above some age, you will get maternal death. If it is under any person under 1 year, you will also get infant death. If it is male, 33 years old, you don't get infant death or you don't get maternal death. Okay? And then I'll click on save. So this is just to review what you have selected and how things are around here. Just a simple data entry with all the other things. This was also available in version 1. But what is different here is, in many places, they wanted to enter multiple causes of death in the same line. So, like for example, here, I don't want to take this one up. Let me, let's just say, diabetes. So you can keep on adding all these things, and when during the DHIS calculation, it will just select what is the exact underlying cause of death. Okay. So when we started this one in 2021, and we made DHIS calculation was, we were still learning about all the process and everything, how things are and how things were going around. So for the first version, we could just select only save. We can click on certificate. So like here, you can get the disease name and everything put down, including the ICD code and everything up. Okay. So like here, you can get the disease name and everything put down. And if you want to complete one process, you can complete it. Like I say, let me enter this one. I'll come back tomorrow and try to do. That's also fine. So, sorry. Let me enter this one. I'll come back. Just in the top. That's also fine. The certificate option will be available only when you click on save. If you don't click on save and you don't select underlying causes of death, you cannot generate certificate. That was the one of the hardcore rule which we included. You can enter all these different things. If you don't select underlying causes of death, it won't do the things. Yes, please. If you don't select underlying causes of death, it won't. Select? Which select? Yeah. Like here, the description. Because like when we write, we already have, but like we can try to get the description too around here. Because like when we write. Yeah. But like we can try to get the description. We'll just write that one down, yeah. Just write the description. Yeah. We had that one. We just write that one down. Yeah.
So the issue is flow of text. So when you select, if you select especially multiple causes on one line, you will have descriptions, and then things start to look not really that great for the person trying to kind of interpret this. So, yeah, I mean, these are very specific maybe requirements for this. I mean, maybe in Lebanon something specific has to be done. What we're trying to present is a generic tool that can, of course, be modified a little bit, I think, but we're trying to also make it such that it's presentable and easily interpretable, following standard guidelines. Specific guidelines that need to be implemented in a specific place or extra features, that can be done. Yeah.
Like, for example, here. So before, when we actually made this one, we didn't have this DHIS tool at all. This was later stage. And then people started to complain, oh, in DHIS, like here, we can had multiple causes in the same place. And why are you not giving us that one? So that was the reason. The first version when we had, where you had only one causes selected, then like you could have actually just see the whole things. That was still there. But like now, like in one particular place, if you enter 2 or 3, we cannot include all the descriptions in the same cell. Maybe like we can think about some other way after trying to show it, but maybe like however have a tooltip to show the description, that may be possible. Okay? Yeah, we'll move on very quickly. Like what are all, because we are just like dealing with data entry only. Okay? Very simple. Try to do all the things. In the older version, we were splitting into from A and from B, like we were doing that one in the different places. So now it's everything is combined, so it's easy for us to actually review all the places, what has happened, how things are, so that you can go back and actually just see what DHIS tool is saying. And then the other thing was, like when the DHIS already selected one, underlying causes of death. What did it select? Like when the DHIS already selected one, underlying causes of death. Like for example here, nah, this is not right. I want to change it. So then I'll just switch to manual. Like for example here, and then I say this is not right. There is nothing there. So then I'll just switch to manual. And just say, then like you have to few reasons. These are something which we came up with by talking with different people. One is certificate is already distributed. And then they are doing the data entry after the certificate has been given. And then they cannot change the underlying causes of death. That's one. The second one is medical officer not agree. For example, the DHIS selected this one, the empty cell. We said, no, that's not right. I know it is diabetics. So let's just say medical officer did not agree, or DHIS gave wrong underlying cause. The reason why we are trying to do is, then we want to try to collect what DHIS has been given and what people are selected. In your analysis, in other things, then we can try to actually just see and compare how much the DHIS online tool has helped us in reducing the effort of doing the underlying causes of death. Okay? So I'll just click on here, because DHIS gave a wrong reason, and save. Only when you save, you get the certificate. Okay? So this is the process which was not there in the first version, because like there we only had DHIS and people can uncheck and select underlying cause of death, but we were not recording it, what DHIS gave and what was the manual one. So those were implemented in the second version run, and also combining all the different kind of things. It's fine? Okay, so enough of data entry. So let's just go for the chart. Oh, one other thing. I just want to show about the completeness. So I'll just like save, go back. Good, people are entering the data. So Lily Fox was I created. And then like if you just see, these are not completed one. Oh, we had a section on complete. When I click on complete, then like you cannot edit. There was a place about complete. I'll come back to that one later. Let me just quickly just change. Knew you had. Okay. Okay, so now I'm in Cheetah Hospital. Thanks, you have entered some of the data. Okay, so now I'm in Cheetah Hospital. But not selected the things or saved. Some of the data. Just register the patient, but not enter the medical details. You can try to enter the medical details and try to just search, okay? Just register the patient. Anyway, this demo site is there. Please go through and like enter all the things, and if you have any comments, you can always tell us. So now let's just go for a few of the nicer things. I go for dashboard. These are all built-in dashboard, and all the data what we imported was for 2023. These are all built-in dashboard. And I select for the national level, which is training land. So these were the few of the charts which we have created. These are the chart which is inbuilt. This doesn't mean that like you are not able to do the other charts. DHIS2, the event visualizer, all the things which Pramod mentioned, Pramod and Saurabh mentioned, you can still do it. These are some additional inbuilt chart which you can try to use it without creating all those things again. Okay, one is by age. This is by all the different causes of death, and this one by the causes and the chapters. Then you can try to just select mortality by different diseases. You can try to include many other diseases if you are selected with. So this is up to you to just select most of the different kind of causes. And if the data is there, it will just show around. So this is up to you. I'm just like selecting few of the things. And if the data is there, it will just show. You can also type. Say, you can also type. Diarrhea diseases. So then like you can just like click one. Based on your requirement, you can just like try to keep on adding. Or if you just say like, okay, I just want to remove this one, so you can just like click it on. Come back on. Okay. Again by NCD, non-communicable diseases. These are the most frequent causes of death. Chart, all things. ICD death by chapter, which you can try to do, and malaria, TB, and other places. Is that okay? We also have Anaccord export, where you can try to click. I'll come back to that one a bit later. So this one is the interesting part. Like the translation is there on the fly. Okay. So now I want to try to add a language. You can just select, let's just say, Bengali. Like these are the different things what we can try to just see. Bangladesh or India, sorry. Let's just say Bangladesh, add. And then like you can try to add. These are all the keys what we use. Like for example, search, list, exit, page, profile. Those are the different, and these are all the English, French, and other words. So you can translate all these different things and send it to us. We can try to help the other people who can try to use. Or if you don't want to send to us, just want to use for yourself, it's also fine. Okay, you can enter all these things, save it, and you can try to, when you change the interface, it will also change that one up. Okay, and there are different modules. For each module, you have the translation keys. Like for example, for the data entry, for Anaccord export, for dashboard, for administration, and for things. Most of the time, you don't want to translate the administration because people are technical, and then end user is not seeing that, so you don't have to worry about that. So including the translation also. So one of the main thing is the data entry part, Anaccord export. You just see, select the year, run, export to Excel. So those are different kind of things which we can actually translate it up. And then is the dashboard. These are also something which we can try to translate, but the percentage, the dashboard title. Those are the different things which you need to try to include. Okay. Yeah, this is the part like where only the administration people who have the access to change. So for example, I want to include few more attributes you can try to include in the death certificate. And here, where you can try to upload a logo, whichever logo you want to try to include, where it has to be, what data you want to try to include around here in the body, and under here, add a footer item, you can just say, I want to include enrollment date. I also want to try to include some places, they would just want to include only underlying cause of death. Some places, they also want to try to include A, B, C, D. That also you are possible around here. So you can select whatever field you want to try to include, which you can try to put it in. Okay. Yeah, that's up till here. Any questions? Have we gone very fast, or because we still have IPD1? Yeah, that's up till here. Any okay? Have we gone very fast, or because we still have okay? In the dashboard, you just click on the dashboard. Okay. Here we just select 2023. Okay. In the dashboard, you just and then we can just see list of all the things. Okay. 2023. So dashboard and 2023. And here, this is the list of all the different type of dashboard which is there. So dashboard, I just say frequently cause of death. So then you get frequent cause of death. And these are, like I just say, okay, why can't we make other dashboard and all things? And I just say, please, you feel free because it's DHIS2. People can try to create any kind of dashboard, any kind of charts, what they want. Okay? Yes, please. Yeah. You will. Because like all this thing is inside the app. So when I talk about the app, this is the causes of death app. When you install the app, you get data entry, you get dashboard, you get translation, you get administration, everything inbuilt inside the app. You get dashboard, you get translation, you get administration, everything okay? Inside the app. Yes, because like here, this is our DHIS2 dashboard, right? That's the overall dashboard. Okay. So one of the things, the reason why we want to try to inbuild was there were so much dashboard created everywhere, and people were having access to try to get only for this one. This is just like to just say if people are entering the data and focusing on causes of death only, and these were some charts which we created, which will be useful for people to view. If they want to use the DHIS2 dashboard, it's also perfectly fine. These were some of the dashboard which we just say people are creating the dashboard again and again. So we just wanted to reduce the effort to give them those features. That's it. Okay. I just quickly want to. I'll stop my presentation for 2 minutes. I'll just quickly want to. I'll stop my presentation for 2 minutes. Okay. Is it on? Great. So before I move to the IPD part, I just want to show you how things happen. How does the installation happen at your own DHIS2? So you download the DHIS2 instance from App Hub. So how many people have gone to DHIS2 App Hub? You can just search DHIS2 App Hub. In here, this is the DHIS2 App Hub, which you can also get it inside the DHIS2, depending on your version. So I just say. So here, this is the causes of death. You can download this one. upload in your DHIS2, or within your DHIS2 itself, you can just select this one. Once you select, it doesn't mean that like you have installed it once you upload it. What you have to do when you run the first time, it will ask you this screen. What you have to do when you run the first time, it will tell you, is that okay. It will first tell you where is your ICD 11 hosted, whether it's in the global server or you have installed it in your own ICD 11 coding tool that you selected, and then it will show you default or custom. Okay, I will not go for default one. I'll click on custom installation. Where you select, I will not go for default one. I'll click on custom installation. Where you select, so first thing what you have to do, you have to select your tracked entity. That means whether it's person and all. And here these are all the mandatory fields which you have to select. And then you can add additional field, like for example, patient address, patient passport number, or national ID, what is there in your DHIS2. You just select those fields and it will like import it. This is before, this is during the installation. When you upload the causes of death app in DHIS2 and run it, the first time you have to do this one. And you should have admin user or super user privilege so that like you can try to do this one. Yeah, and then like if you want to create any additional sections, for example, I want to also know about the investigation details or classification details and other things, you can also try to include all those things. And once you have done with that one, this is the important part, is you have to select the MCCOD is being collected where? The causes of death app you are going to assign to the hospital, central level hospital only, or central level hospital and referral hospital, but not for district level hospital and the health center. You select those things. And then other part is, what is this, what are the different users you want to try to do? These are different, we have 3 different types of user groups which the app will create. First one is data entry user. That means the people can only do the data entry. Second one is view only. That means the person can actually view the data but cannot do any changes in the record. The third one is admin user. That means he can add more field, do the translation, change the death certificate, so not death certificate, but medical certificate for causes of death. You can add more fields. So those are what we call admin group. So admin, view, and capture. These are all 3 types of group which you should have in every tracker program. The same thing, like we have been trying to do that one in the causes of death. And then like you can try to review, and the installation is complete. This happens within your DHIS2. First thing, you install the app in your DHIS2. When you run first time, it will ask all these different details, and then it is complete. Then you can see the data entry module, you will see the dashboard, you will see the Anaccord export, you see the administration, and you see the translation. Okay? So these are all the things. It's an installation guide, which will also come around into different places. Okay? So these are all the things. It's an installation guide. Okay, now let's just like quickly move to other part. I wanted to give you a bit more time on doing all these things, but I've seen some people have already gone and did the data entry by themselves. Well and good. If not, you can always go and do this is there. The same username password, we haven't changed it. You can always try. And if you have any comments and things, you can always write to us. The same username password, we haven't changed it. You can always try. And if you have any comments, this part is what we want to try to spend for next some time. So after this one, what happened, especially in Bangladesh? So WHO 0 and WHO Bangladesh and Minister of Health Bangladesh and DHIS, they wanted to just say like we also want to try to have a module with mobility and its linkages with MCCOD. So this is an app which we are building right now, and it's been like also been trying to use that one in Laos and also like in Bangladesh. So the main thing is to capture mobility data. You register a person one time in one place, and then like he can go to different org unit. I just say he registered in Da Nang, and then he went to Ho Chi Minh City, and his details should be there, and we enter those data. So that's the one of the things. And then the causes is the main cause only is from ICD-11, so that like we can try to compare. And we can also review the old ICD discharge summary whenever he came around. That's the other part. And link the IPD and MCCOD data. Not the data part, like one person like is entered into inpatient discharge place, and then like we enroll that person into MCCOD program, so that like the people can enter all the medical history, but they don't have to enter the first name, last name, address, and all different things again and again. But they can enter the causes of the death into MCCOD part itself. And then do the same kind of analysis, top 10 causes of diseases by chapter and all different kind of things. Those are something which we are trying to work at. The opportunity is, the IPD usually like most of the country, what we've been seeing around here, even whether it is Cambodia, Laos, or in many other places, we always want to try to collect IPD data, broken up by gender and age. And then like it takes long time, and lots of data quality issues are also happening because people have to fill in exact that particular box. That's one of the way. But like by using this IPD discharge summary, we can try to do that one. Along that one, we can also do average length of stay based on admission and discharge. And then we can also do the midnight head count. Sometimes what happens, like the people just say, my bed occupancy rate is 200. Maybe the person comes down in the morning and just get the IV, stay for 1 hour and then go. And then second person comes down. So then like we don't know what is actually midnight head count. So that's what like we just say one person has used the bed for many times. So this is other way of trying to just see the hospital load. That also is possible around here. Whether you want number of count or number of midnight head count. Also it's something which you can try to do. The challenges, I'll come back to it a bit later. What I want to try to do is a quick demo. Yep. Sorry?
What version? Is it 3.9?
Oh, MCCOD app is been, we designed it from 36 up.
36 up.
Yeah, until 40, 41, 42, 43, 44.
Okay.
Which is not there yet, but like when it comes down, it will still be there.
Thank you.
So MCCOD app, like one of the main thing, we've been testing everything. If you look around here, this is also, which version? This is 35. Okay, so many of the places, I don't recommend you to not upgrade, but like anything, please upgrade to the latest version. But the MCCOD app is been supported from 35 on to 41. In most of the other countries, we have been using 40, 41, 38, all the things, we are supporting that one. So don't worry. In most of the other countries, we have been using 40, 41, 38. So let me just quickly go back around here. So now what I want to try to do is on IPD. There are few good things around here. This one is also a new technology where we want trying to implement. We haven't done many of things. This is the reason why we are trying to show, like you can give us more comments and just see how things has been used in your place. Simple, the same way. Let me try to register. I just say Roger, David, male, blood group, date of birth, we can also try to use. I just say 77, Accept. Oops. Okay, the address, passport details are the same thing. This is the same way of what you did the registration. So now I'm registering one person is this Cardial Hospital. The patient is registered only one time. Just want to move this up. Click on here. And this is now what you're trying to do the admission. So let me just say he was admitted or discharged on June 29, and it was admitted in June 25th. Accept. And this is the ICD-11 thing, so let's just say he was admitted for diabetics. And this is the ICD-11 thing, so let's just say he was admitted for diabetics. Okay. Save. And then let me just say, no, not diabetics. Let me just type about delivery. Save. And then okay. Let's just say single delivery. Okay. So then I'll get a message. There's something in the red that it says male cannot deliver. That's okay. So I just clear it, and then I just select diabetics. Male cannot deliver. That's okay. So I just clear it. Save. And then you have preconditions, as hypertension, like other things. IPD, whether it is, just say it was medical. And then discharge status. Like what we have is improved and discharge, discharge on request, discharge on risk bound, and then absconded, transferred, and expired or died. Okay? Let's just say discharge and completed for now. So the reason why I want to try to do this one is let's just say Roger David is been admitted in this hospital. I'll go back. I select the cat. I select the cheetah. Health center. I don't find anyone. Okay. Let me just find Roger David. So then I find the person. And now this person who's in Cheetah Health Center can actually look at the data, but he cannot do any kind of modification. What he can try to do is just to add. So I click on add. Let's just say date of discharge is in September 21. Date of admission is 18. IPD number. These are all different things which you can try to include more. And I just say IPD number. Heart failure. Okay. You can enter in free text. Diabetes. Surgery. IPD. And now I'm making this person die. Let's just see what happens. So did I do something? And then you just say date of death was, so wait 1 second, 21st. And then you just say date of death was, and submit. And what it does, it will show to you a message just saying, are you sure this person is dead? We will include this particular person. We'll enroll this particular person in causes of death. I just say confirm. And when we go back, we can just actually just see this person is registered around here. Now I will go back to the causes of death. We can just actually just see this person is registered around here. Now I will go back to the causes of death. I select the same Cheetah Health Center. And now you can just see Roger is already here. I select the same. So all that is details, the age, date of birth, address, and everything will be there. But this one will be blank. The people can try to have to investigate and enter all this different data. What this one will allow, the person can actually see is all his medical history, what happened in different places. That's also something which we can try to do. And we just say, okay, take me back to the IPD event. so that like we can actually just see all this data. Okay? So we are not, one of the things, we are not going to fill all these different details. That will be very bad. So then like people just like click. So we want them to use this app where we can try to reduce only the effort of entering the registering person again, all different kind of things. But all the medical conditions, medical things, they have to enter those data again. Okay? So now let's come back to this challenges. It looks very simple, but it is not. When we talk about IPD, is delivery IPD or not? Delivery, cesarean section. Is it part of IPD? Inpatient department? Daycare? OPD? No, come on. At least I know it is not. The reason why I'm trying to ask is many countries have implemented delivery registry, for example, Laos, where the person have to enter the data. In some places where there is no delivery registry and all kind of things, okay. But like in the hospital, when I want to see, I want to know how many hospitals have been used for delivery and what is the average length of stay, which is part of hospital administration unit. At the national level, we want to know how is our hospital is doing. That's why you're trying to do this IPD, right? What is your bed occupancy rate? What is your average length of stay? How many people have been, what kind of causes you have? And this is not OPD part at all. The challenges comes around is there are already existing systems working. For example, one use case is dengue, which is also very famous. Dengue is also been collected in OPD and also in health centers where there are no IPD at all. And if we just say you have to include dengue in the IPD part, so that like it's useful, then like you're not, the dengue people will just say, I don't want to use the data because I want to see the entire country dengue details. But the national level hospital, the administration, the manager, he will just say, I want to see all the dengue cases in the hospital. So then like we need to make, these are challenges which are not technical challenges. These are more non-technical challenges where we need to share the data. If people are entering the data, like for example in Laos, what we did, no IPD will enter delivery details at all. All the delivery details will be imported from delivery registry, where they will just say, if a delivery happens in a hospital, we have data of admission, we have data of discharge. So we take the data and we push it to the IPD. So in other countries where we don't have delivery or delivery registry or other things, so then IPD can give the data to the MCH or to enroll into other places. So these are all the challenges which we try to come around, that's when we need to talk to all the different program people when we try to implement. If we just want to focus on, I just want only IPD, that's fine. And then people will come around, can you include malaria? Can you include TB? Can you include all these things? Then like we need to know, then you are disrupting the national health program. So these are a few challenges which we need to take into consideration before we implement the IPD as a whole. First, why do we want to try to do the IPD? Yes, we want to try to do the IPD only on these things, it's fine. It's easier. But like then like we also keep in mind what are all the different data we have collected in different systems. Whether we're trying to get it from there, so that like we don't ask our IPD staff to enter the data again and again and again. Because delivery data is entered in delivery ward, which is not part of the IPD ward, inpatient department ward. And then like, this is also not EMR or hospital information system. In a hospital information system, we can collect everything. But when we want to try to report, we only report main causes for inpatient. We don't include all the causes. That is okay to include in EMR. For our analysis, what is the top 10 causes for admission? We just need one cause. In many places, we have seen like to include cause 1, cause 2, cause 3, cause 4, cause 5. Especially in Laos, the people is sitting in the back. So those are all the things we should not include because we cannot do any kind of analysis at all. All the other data, you can keep it in your EMR in the hospital system, but have only the main cost, so that like we can reduce the work burden and also do the analysis more easy. Okay? So I will stop around here. If you have any comments or any questions. No questions? Everyone tired? If you have any comments or any questions. We will open this one up. This is online, is still there. Please have a look and you can try it out how things working. We will open this one up. This is online, is still there. Please have a look and you can try it out how things working. Okay? No questions? Okay. I know it's a long day and many people have just traveled today. So, okay. I will give the floor to Sam. Many people have just traveled today.
Okay, thank you so much, John, for the ICD and the IPD. So I think that's all for today. So we don't have anything, right? So yeah. So today we now it's 5. So remember we have the gala dinner at 6. So we are on the 25th floor. So everyone is invited to join. And tomorrow we will start same room at 9, right? Okay. So if we don't have any questions, then I think thank you everyone for the attention and for the first day. I know it's quite long, but yeah. So thank you very much. Thank you very much.
Okay, just say bye to everyone and then say there's a different Zoom link.